Good afternoon. I think we had to start now. 5 minutes pass. Uh, our first speaker is Dr. Imad Raha. He will give us a lecture about HER2 scoring in breast cancer.
السلام عليكم.
Good afternoon. Welcome دكتور عماد. نحب نشكر جميع الحضور على التواجد معنا النهارده في الباثولوجي راديولوجي سيشن، وده ده يعتبر عرف بدأته بهية ومكملين فيه يعني لسنة بعد سنة، وهي دي حاجة كويسة جدا بتخلينا نفهم بعض، يبقى في كومون لانجويج بين الباثولوجي وبين الراديولوجي. احنا بنقول لكم الحاجات المهمة من وجهة نظرنا من السكوب بتاعنا، وانتوا بتورونا الموضوع من الجراف بتاعكم. ف I hope ان احنا بنهاية اليوم ان شاء الله نكون adding values for each other. ومتشكر لجميع الحضور، متشكر للتشير بيرسونز اور فاليد تشير بيرسونز، يا رب موجودين معانا كل سنه ان شاء الله. وايفن حتى مش هنستنى من السنه للسنه، يبقى في حاجات ما بيننا وما بين اقسام الاشعه، يعني كل شهر وكل شهرين يبقى في ميتنج ما بيننا. ده اكيد هيوصل المعلومات اللي احنا عايزين نوصلها لبعض، وهيعمل بريدجنج جابس، وهيعمل شورت كاتس ما بين حاجات كتير احنا محتاجين بعض فيها. دكتوره مهيتان.
Welcome everyone to our pathology radiology workshop. Today we will enjoy some valuable insights in pathology practice and radiology too through interesting lectures provided by our esteemed lecturers. Let's start with Dr. Imad Raha. Dr. Imad is a professor of breast pathology and honorary consultant pathologist at the University of Nottingham and Nottingham University Hospitals, UK. He also works as a senior consultant in Hamad General Hospital in Qatar. The floor is yours, Dr. Ahmed.
السلام عليكم. شكرا. اعتقد كلنا باثولوجيست، صح؟ في حد مش باثولوجيست؟ في راديولوجيست؟ طب معلش نخليها بس باثولوجي بيزد، بس في راديولوجي برضه مش مشكله. فهنبدا على الهير 2. as we know 15 to 20% or current, if you look at the data previously you will find 20%, 25%, 30% HER2 positive. This is before the guideline. If you look at recent data, in UK about 12% now, HER2 positive, 12%. If you America, Europe, something up to 14%, 15%. In Middle East, 20, 25, between 20 and 25. So it is variable based on the ethnicity and the age and biology of the tumor and. But say 15 to 20% of breast carcinoma are HER2 positive. HER2 positive means that it is driven, the growth of breast tumor is driven by HER2. So what we are detecting actually is the oncogenic status of HER2. Because this tumor is driven by HER2, if you kill HER2, the tumor will die. So that's why it is very important to identify HER2 positivity in breast carcinoma because of treatment, treatment. Two things, one is prognosis and one is treatment. HER2 is associated with poor prognosis. If you look at this is before anti-HER2 therapy, this is double positive, ER positive, ER positive, BR negative, luminal B, and this is triple negative, and this is HER2 positive. So HER2 positive associated with the worst outcome. If you give anti-HER2 therapy to this class of tumor, they will move to similar to luminal B. So HER2 is a prognostic marker. HER2 positivity is a good prognostic marker indicating poor prognosis. At the same time, indicating a very good response to anti-HER2 therapy. That's why most of the guidelines, this is from America, ASCO-CAP guidelines, they try to split HER2 positive from HER2 negative. And they focused on HER2 positivity, how to identify HER2 positivity. They didn't care about what is beyond. If it is negative, lump it together. If it is positive, it is this, like this. And how do you know HER2 positivity? This initially did overexpression. Overexpression 3+. So what is the story of 2+? They found that from analysis of some of the trials, they found that some borderline amplification, some borderline expression, if you have gene amplification, those patients are more likely to respond. And they said a cut-off, random cut-off, not accurate, at HER2, for example, ratio of 2 or copy number of 6. So this is just because you have to have a cut-off for consistency of reporting, not indicating the level of response. So if you have a tumor that is 2 plus and the ratio of 2, this is amplified, but this is very unlikely to respond. So it is the more you have protein expression, the more oncogenic activity, the more likely this patient will respond to treatment. And the same with the previous UK guidelines, the main distinction was between HER2 positivity, including 3 plus and 2 plus amplified, and even in the guidelines of the UK, this was actually, I did it, I combined 0 with 1 plus. Because there was no point of separating those together. Just as a pathologist, this is very nice. HER2, when it is positive, 100%. Strong, complete membranous staining. You can have this one. This is called heterogeneity. So you have two clones. One is positive and one is negative. This is called the clustered. So you have one cluster which is positive and one cluster which is negative. You can have another type of HER2 which is called like mosaic type. So one cell positive, one cell negative, as you can see, scattered or like this one. Okay? So it is a bit mosaic in appearance. So the other one is one clone and one clone. This one is just within the same area. You may have some cells positive and some cells negative. And in these cases, we use 10% cutoff. So if you have 10% cutoff positive, it is HER2 positive. And the 10%, be careful because we assess on a core biopsy. In these cases, if you have a case like this and you have only very scanty tumor cells like this positive, so I will recommend repeating HER2 on excision. I will not call this negative because it's less than 10%. If according to the guidelines says that if it is less than 10% strong, it's 2 plus. But how do you ensure that fish will pick up this tiny small foci? So you have to be careful. Even if you fish it and it comes back as negative, you may stain the full face. Those patients better not to be treated with a new adjuvant, and you have the excision, and then you assess HER2 on a different blocks. Or ask them, if they are very keen on new adjuvant, ask them to repeat the biopsy from different area, because you may get a positive clone. If you have a case like this, is this positive or not? Majority will call it positive, right? But how do you know positive? Because it is a bit of a strong membranous staining in this. Very important because what is the difference between 2 plus and 3 plus? Is 2 plus is moderate intensity, 3 plus is strong intensity. How accurate are we in consistency? Or what is the level of consistency among us in differentiating moderate from strong? It's not very hard. So when you see something like this with a spectrum of positive, weak, moderate, a bit more moderate, try to focus on, look at the internal control and compare. If you have the same level of intensity, strong. If it is weaker than the level like this one, so compare this one with this one, I think it is. So you can call this one, it amounts to strong, so it is positive. Because it happens several times that when you have a spectrum of staining, definitely one of them will be stronger than the next to it. And this is strong, this is weak, oh, it is positive. But in reality, this is moderate. Look at the internal control within the slide, not the tissue internal control. And another example, how do you know? You have to look at the control. So the intensity, if I have something like this, I think something like this is not amounting to. So you have to be careful, make your own judgment. It's similar, and this is, as I mentioned, we are not concordant in the assessment of the level of expression. It is very subjective. So how do you improve our concordance? By having a reference, standard reference, which is the positive 3 plus in your slide. So this is something I already have mentioned here. It is borderline. So this is much weaker than the previous, as we can see, much weaker than the previous slides. So we call this 2 plus. And if it is strong like this, yani upper level of moderate, usually it will be amplified. And this is the one at the top of amplification. So you have ratio of 8, ratio of 6, so higher level of amplification. Something like this is, I have seen, by the way, this case, similar to it, was called as HER2 positive because of this intensity. But if you look at high power, you will find the membrane is not complete, the intensity is moderate. So this is, by definition, this is borderline. So don't be, because you have something like negative here and something like, can you see this is a bit, looks strong, but look at the completeness of staining, look at the intensity compared with the control. So this is 2 plus, and then send to fish. Another example, this is a bit more complete membranous staining, but the intensity is not up to strong, so 2 plus. Is this 1 or 2? So this is the area where we err. We both of so if I am confident, I have some of my colleagues, they will call this 1 plus. Personally, I will call it 2 plus. So it is why, because we are worried that if I call it 1 plus, it will not be fished. If I finish it and it comes back as negative, I didn't cause any harm, because 70% of cases we fish negative anyway. So, but what? How can you confirm if you don't have facility for fish? You have to have complete membranous staining. So if it is weak, like this staining between weak and moderate, is it complete or incomplete? Something like this. Okay. So if I think this is complete and this is moderate, so it is 2 plus. Okay. But compared with this one, so can you see the previous one with this one? So this is a bit staining as well and membranous, but it's weaker than the previous one. The other one was moderate, this is weak. And this one is mainly incomplete, so this is 1 plus. So don't worry if you call something like this 1 plus. So there are some areas, it has to be at least weak, and more than 10% of the cells. If you look cell by cell, 2 cells within same membrane is not counted as membranous staining. It has to be around each cell. So if you look at each cell, this is, for example, not lacking here. This is lacking here. So if you look at each individual cells, like this one, so you have lines, but this line is not circulated or surrounding every single cell. Okay? So, and as I mentioned, in some places, they will call 2 plus because they are scared of missing one. But this is 1 plus. So the definition is weak or moderate, complete more than 10%. To call it 2 plus. If it is weak, incomplete, this is 1 plus. Even the definition, according to the definition, moderate, incomplete, they will call it 1 plus, incomplete. So if you look at the algorithm is not complete, is not filling all the items. But if it is incomplete, they call it 2 plus. But definitely, if I have moderate, incomplete, I will fish it. Okay. So the intensity of it, as we will discuss later. So this is something you can have DCS positive and the tumor is negative. So it's very important when you send it to fish, don't send it like this. You have to tell the guy who is doing a fish that he scores this area. So you circle the area of invasive, because otherwise he will score DCS. And in the guidelines, you will find some representation and illustration of what is 1 plus. And so something like this, different scoring. So look at different images of 2 plus, different image of 1 plus. And if you are in doubt, better to fish. If you are in doubt. If fish is very difficult, go back and review. You may be happy to call it 1 plus. Is this positive or negative? Why negative? Yes. So we don't consider cytoplasmic. Any apocrine lesion will be like this. Apocrine carcinoma, apocrine metaplastic. This is carcinoma. So, but granular staining is not counted. So ignore it. Nuclear staining counted? No. So some cases, occasional cases, you get nuclear staining, you get cytoplasmic staining. Is this positive or negative? This patient was scored. This is a mother of one of my students. She was diagnosed as 3 plus. Had treatment, didn't respond at all, and then they questioned and then they sent the case. So I looked at it like this. I said, does it look like positive? So look at the background. This is excessive antigen retrieval. When you have excessive antigen retrieval during the process, you stain everything. So background has to be clean. Look at the background of the stroma, background of the normal epithelium has to be clean. It's not stained. If it is stained, you have overstaining. Okay, so this is a false positive stain. This case was repeated completely negative, 0. It's not even 1 plus. Remember, HER2 can change after neoadjuvant therapy. So you can have HER2 positive before treatment. When you have excision, you can have HER2 change from negative to positive, from positive to negative, due to heterogeneity, due to enrichment of a clone that was scattered and something, or due to therapy induced. So you can have a proportion of cases. So this is communication between you and the oncologist. If it makes a change, if it makes difference for them after neoadjuvant, should we stain or not, we can stain. If it doesn't make, if they will not change the protocol, there is no point of stain. But it is important in some cases of HER2 negative, If you see the tumor aggressive and something, you may stain the aggressive area because you can have heterogeneity. So this will benefit the patient, especially this patient didn't respond, and the residual tumor is aggressive, and it was HER2 negative. And you look at some of the morphology of HER2 positivity. Cells are a bit eosinophilic. They don't look like triple negative. So if you have features raising concern about HER2 positivity, you can stain after neoadjuvant. Remember, this is a study that we looked at difference between 2+ and 3+. Can you see the difference? The response of 3+ is this one, and the response of 2+ is this one. So those of oncotype DX, this is similar to oncotype DX. So you can stratify your patient group by using any of our criteria that we already use: grade, size, intensity of staining. So 2+ is completely different from 3+, and you can tell your oncologist that this is 2+, this is the response is low. As we mentioned, the standard of care now for HER2 positivity. What about HER2 negative? 60% of cases will be HER2 negative. So they tried to use trastuzumab in this patient, and they didn't show response. And then after some time, they tried to use TDM1, which is antibody drug conjugate, but it didn't show response as well. So after some time, they said they developed a new marker, new drug called the TDXD, trastuzumab deruxtecan. And it is based on this is a trastuzumab, the antibody itself of the trastuzumab, and this is the chemotherapeutic agent, like chemotherapy, and they link it to the tumor, to the antibody by something called the linker, and then the antibody will be given to the patient, and this drug, the antibody trastuzumab, will attach to the HER2 receptor, and then release first get inside the cells, and then release the chemotherapeutic agent. So the chemotherapy is released inside the cells, not outside. That's what is called the antibody drug conjugate, and then it is released inside the cell. And there is a hypothesis that after you kill the cell, the dead cells will release the chemotherapy and then kill the neighboring cells, called bystander effect. Bystander effect. So, and then this is the concept before, and then they try to test this in clinical trials, and they found a response of HER2 low. Means that the cases with HER2 2+, non-amplified, or 1+, they responded to this type of treatment. So they used any level of protein expression to just use it as a method of transportation or moving the antibody into the cells. It's called the HER2 low. So they defined 2+, non-amplified, plus 1+ together into one group called HER2 low. And this group can be treated with TDXD. But when they described the TDXD, it was described for metastatic setting, not for every single patient of breast carcinoma. So the patient will be eligible for TDXD will be the metastatic one, not responding to first line, second line. And then after this, there is another clinical trial that extended the use into a first line chemotherapy after CDK4/6 inhibitor. But until now, as long as your oncologist is not giving this treatment, don't worry. If the oncologist started to use this treatment, you need to pay attention. And the paying attention is how to score, because now, if 2+ non-amplified, easy, because we already pick it up. It's already in our routine practice. The only thing is how to differentiate between 1+ and 0. Okay, so this is published in New England Journal of Medicine, and the 2 trials, and the 3rd trial, and the testing, and they extended into ultra low as well, and so on. Okay, and we tested this one when it attracted a lot of attention. Is this unique, or just for a group just for targeted therapy? So we found there is no biology. So HER2, when it is low, when it is not amplified, is not overexpressed, it doesn't affect the biology. The biology will be driven by something else. But the treatment is not targeting the HER2. The treatment is using HER2 as a protein, as a receptor only. So I don't care if the biology of this tumor, aggressive, not aggressive, driven by ER, is not driven by HER2. Okay? And in the clinical trials, the inclusion criteria was the same antibodies that we use in our routine practice, 4B5, which most of us use it, Ventana 4B5. So it is the same antibody and the same setting, and using the ASCO-CAP guidelines. So don't worry about sensitivity and specificity, because the inclusion criteria is the same that we are using in our routine practice. So I don't want it to exceed the inclusion criteria and have very sensitive kit. Because if you use sensitive kit and then you pick up something which was called negative, how do you know that this will respond? So we don't worry about using, no change of practice. You continue using the same kit. There are some publications, you see that the kit is not developed to pick up the low level of expression. But in the trial it was used. So there is a little bit of discordance between labs, but this is acceptable at this stage. So don't worry about the antibody. Just remember, when we assess here, we assess the pattern, membranous, cytoplasmic, something, intensity of staining, and extent of staining. Is it 10%? Is it 5%? What is the percentage? And do you have heterogeneity or not? And when we assess the intensity, negative, faint, weak, moderate, strong. You 5 variables, and then percentage, at least 2 variables. So you combine together, you have like more than 20 permutations, 20 situations where you can have complete, incomplete, strong, weak, moderate, and then so how many of the scenarios described in the ASCO-CAP guidelines or in the IQ guidelines? About 8 out of 18. So there are some cases we have to use our mind how to. This is the reason for the update of the UK guidelines. We try to make it easy for us to improve concordance among pathologists. You use the same scoring criteria. So we developed this algorithm. If it is strong, if it is moderate, weak, and faint, and each one you have strong, complete, incomplete, and then the percentage, and then this is from the guidelines and from one of the publications. So if you use this one, if you print some algorithm like this in front of you and then put it and then follow, you will have consistency. I'm not saying accurate or not accurate, but at least consistency among us, because we are following the same thing. The problem with ASCO-CAP, because there are some missing scenarios, so each one of us will interpret differently. And again, we updated the UK guidelines and included definition of 1+ and 2+, but this was updated before the invention of ultra-low. Additional point related to the HER2, as I mentioned, which pre-analytical, pay attention to fixation. This is very important now. For HER2 as in general, and the ER, fixation, pre-analytical variables. But it can affect ER low or HER2 low. So pre-analytical variables, what type of specimen? You assess whatever you have, and if they mentioned if it is 0, you can go back and look at the previous one, or anyone positive will anyone weak or HER2 low will qualify for the trial or for the treatment. Okay, and remember, ASCO-CAP until now didn't approve HER2 low. So they mentioned that it is premature to create a new results. So they said that continue what you are doing. But as I mentioned, if the oncologist asked you to score, we can do it. It's easy. It's just providing a little bit of more details. But this will be in a selected group of patients, not for everyone. Thank you. I will stop here because of my time. Thank you very much.
Thank you, Dr. Ahmed. I would like to thank you very very much. احنا تعبنا حضرتك على مدار اليومين جدا جدا جدا، لكن انا في الواقع اتشرفنا بوجود قيمة وقامة زي حضرتك والله معانا في مؤتمر بهية، وإن شاء الله تبقى بداية تعاون كبير جدا ما بين اسم باثولوجي في أي مكان حضرتك موجود فيه، سواء في نوتنجهام أو في مستشفى حمد، وما بين اسم باثولوجي في مستشفى بهية. شاكرين لحضرتك جدا جدا، وربنا ينفع بعلم حضرتك. و up to the next session.
The next presentation will be about evaluation of histologic response post-neoadjuvant chemotherapy. Will be presented by Professor Maha Egoumei, Professor of Pathology, Alexandria University, and consultant pathologist at Bahia Hospital.
Assalamu alaikum. I will be talking today about the evaluation of response to neoadjuvant chemotherapy. As you all know, these are specimens that we have become more familiar with, and we encounter them more often in our practice nowadays. This is what I'm going to talk about. Neoadjuvant therapy is the treatment that is introduced, whether chemotherapy or endocrine therapy, prior to surgery. In the older days, it was only done in advanced cases, inflammatory breast cancer, inoperable cases, in order to render these cases more operable. However, in the current situation, in the recent days, it has been approved to be used in early stage but large tumors in order to allow for more conservative surgery and in order to allow for limiting axillary dissection and using more sentinel lymph node biopsy rather than axillary dissection. In order to allow more conservative treatment, we are more and more receiving specimens that are that have received neoadjuvant. The ultimate goal of the neoadjuvant is to achieve what we call a pathological complete response. The definition of pathological complete response هي إنه absence of invasive tumor cells in the tumor and in the lymph nodes. So, however, the presence of the DCIS حتى في الspecimen does not preclude pathological complete response. So حتى لو في DCIS, we still say that the patient has achieved pathological complete response. Pathological complete response is associated with an extremely favorable disease-free survival, overall survival, and it is correlated with the outcome, and this correlation is strongest for the triple negative and the HER2 positive tumors compared to the hormone receptor positive tumors. Therefore, the accurate evaluation of therapy response provides crucial prognostic information and predictive information to guide the adjuvant therapy بعد العملية. We have several types of therapy that we have all been reporting in the past years according to the AGCC, whether complete response, partial response, no response at all, or progression. These diagrams show how we see the response. If no response to the tumor size is still the same or even has increased in size, this is progression. Complete response is where the tumor is completely disappeared and is replaced by fibrosis, hyalinosis, and the response that we see. And then we have the partial response. The partial response can be in one of two forms. Either the tumor shrinks concentrically and gives a smaller size tumor. This is the better or the best scenario, but this is not the more commonly encountered scenario, unfortunately. The more common one is when the tumor leaves residual foci. We call it a scattergun or honeycomb appearance. Is we have scattered foci of invasive tumor cells scattered here and there within the tumor bed. There has been several systems that have been developed in order to report the response to neoadjuvant therapy, the AGCC, the Miller-Payne, the Chevalier, Fisher, and so on and so forth. And the latest one, and the one that has been endorsed by the NCCN and endorsed recently in the 2024 CAP guidelines, is to use the RCB scoring system. Even if you are not going to do the score, it is advised that you mention the items in the pathology report. And the RCB is the only web-based system that quantifies, the quantitative measure as a continuous variable using a residual tumor burden in the breast and in the lymph node at the same time. وده موجود for free على MD Anderson website, and this is I think we are all familiar with this, and we have to fulfill certain items in that score. I'm going to go over each and every items and the challenges we encounter in each item and how to evaluate it. And at last, we have to press calculate, and it gives you this residual cancer burden as a score, as a continuous score, and the class, whether from 0 to 3. The first one is the tumor bed, which is the first challenge we encounter when we receive the specimen, and the gross dissection of the specimen is very important in order to identify this tumor bed. The bed is this span of where the tumor was, and it is measured in 2 dimensions, the largest 2 dimension of where the tumor was. This is measured grossly, and then it is confirmed microscopically. So in order to be able to do that, there are certain precautions that we need to take. First of all, we have to know that prior to starting therapy, they usually insert a clip at the site of the tumor because they're anticipating that it will disappear. For the surgeon to be able to identify في الجراحة أو for us to be able to identify it, this clip will always help. Sometimes not only the clip, they make a skin mark عشان to further يعني precise إنه الtumor was in this place. They make a skin mark بقلم بيقول فين كان الtumor. So when we receive the specimen, we have to look for that clip. If we know that the clip was inserted, we have to look for that clip. وعندنا two scenarios. One is ان احنا يحصل incomplete response، وفي حالة incomplete response it's easy لأنه هيبقى فاضل tumor, so you will be able to identify the gritty, firm tumor, grayish white tumor, and then we take the area around it based on the knowledge of the previous size of the tumor. However, لكن لو حصل complete response, it becomes sometimes very, very difficult to identify where was the tumor because it completely disappears, leaving this grayish white, pinkish as tissue that is as soft as the surrounding breast, so you can't even feel it when you palpate it. So the very, very thin serial sectioning will help identify and visualize this clip that they have used, and it's very important to identify it. طب after we serial section the specimen, the ultimate يعني scenario is ان احنا يبقى عندنا specimen radiograph نعمل radiology للسيريال sections and we are able to identify الكليب محطوط فين، وبالتالي ناخد the largest cross section اللي حوالين الكليب دي في السكشنز. The largest one is submitted كلها for histopathological examination. This is an example of a wide local excision. Again, we have to orient the specimen, ink the specimen, serial section it, and نعمل specimen radiography. We X-ray it, and we identify the clip. In this case, this is a bifocal tumor, and we take the area around it, the largest dimension of the area for أكتر section في bed around, when submit it all. طب لو ما عندناش access to specimen radiography, which is the case in most of our practice, في كذا حاجة can help us identify the site. One is this visual identification of the clip. احنا عارفين ان هو حط clip and we serial section the specimen very, very thinly لحد ما بنلاقي هو صغير قوي 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 بس بيتلاقى. We can actually find it. Unfortunately, I don't have a picture, but it's a very, very fine clip. الحاجة الثانية, we always have to have access to the pre-treatment tumor dimension, tumor location, كان في أنهي quadrant, how far it is from the nipple. كل الكلام ده we have to have access to the previous radiology or previous radiology report. And last but not least, the proof of the microscopic tumor bed اللي احنا بنشوفه under the microscope. احنا قلنا ان احنا we identified the tumor bed, the grossing and labeling. The gross section is very, very important. انا هاخد التيومر bed وهعمل له map on the paper where I'm grossing. I have to draw this map واقول ان الماب دي فيها البيد انا واخده السكشنز from 1 to 5. These are the tumor bed. I have to كمان say انا واخداهم from medial to lateral, from anterior to posterior, so that under the microscope I am able to evaluate the size. مش بس باخد التيومر باد, باخد the area around the tumor bed, لأن زي ما أنا قلت أنا yes I evaluate the bed grossly, بس I have to confirm microscopically السايز عامل إزاي. under the microscope السيناريوز كذا سيناريو. واحد إن ممكن اللي أنا بقيسه under the microscope يطلع exactly قد اللي أنا قيسته grossly, so I have to always measure under the microscope. أو إن أنا ألاقي ال area of the tumor bed اللي أنا واخداها ما هياش tumor bed, وان الحته اللي فيها tumor bed او air therapy response او tumor cells viable موجوده only في smaller area, وفي الحاله دي الtumor bed بصغره بقى الميجرمنتس بتاعت الtumor bed بقوسها. يعني it has to be the microscopy هو اللي صح. ف we have to yes the gross هيقيس لنا, بس انا I have to confirm by microscopy, and to be able to do that الليبلينج والدايجرام والمابينج اللي بنعمله is very, very important. والسيناريو الثالث ان انا يبقى فيه في الحته اللي انا خدتها بره التيومر اوريدي كمان في تيومر سيلز او في ثيرابي ريسبونس, فبكبر السايز في الحاله دي of the bed. Again, فاحنا evaluation of the bed is very, very important. It is one of the challenges that we have to measure it accurately عشان calculations تطلع صح في الآخر. تاني parameter هو cellularity, وحاجة مهمة قوي في cellularity we measure invasive and the in situ. These are all included in the cellularity. بأستيميت الcellularity فين في كل السلايدز اللي أنا خدتها that are confirmed as a tumor bed. بقيس في كل سلايد فيها كام field. Let's say فيها 6 fields. So I measure the cellularity in each and every field, واخد average measure للسلايد دي والسلايد اللي بعدها واللي بعدها, and then I take an average measure for all. باخد average measure للcellularity كلها, وبعدين بقول how much of this cellularity is DCIS. يعني let's say the cellularity across all the slides that I have examined is around 70%. However, 20% منهم are DCIS. So I have to put that in consideration هنا في ال RCB form. بحط لأن هو الفورمة نفسها بتسبتراكت ال DCIS ده من الإيكويشن عشان يطلع ال residual invasive هو اللي قد إيه. These are just examples of sections. Let's say this is السيناريو الألطف اللذيذ إن هو حصل concentric shrinkage للtumor. We have the tumor bed. This area is an area of therapy response, as you see, an area of hyalinization and fibrosis. And this is the tumor representing around 50% of that tumor bed. Another scenario, which is the more common, and when you see scattered nodules of tumor with therapy effect area in the middle, again, if we evaluate them من الفيلد كله, هيبقى around 50-60% as well. اللي بنشوفه اكتر واكتر انه يبقوا scattered foci كده around the tumor bed, وعندي definitely this is an area of therapy response, and these foci represent من الفيلد كله حوالي 20%, منهم كان في around 3-5% DCIS. الcommon mistake هنا is ان انا I evaluate fields فيها tumor cells فقط, واقول ان evaluation هنا 20% على الفيلد ده, ولكن في 3-4 fields حواليه that still do not contain any tumor cells بس فيهم therapy effect. في الحالة دي أنا هبقى عاملة overestimation للcellularity, لأن عندي 2 other fields فيهم therapy effect that should be counted as 0, فبقى عندي واحد فيه 20% 0 فبقى 20% divided by 3 is around 6% and not 20%. فهنا عملت overestimation, وهي it's very very important to identify microscopically fields أو slides where we only have therapy effects تبقى counted as well. Sometimes بيحصل من الريسبونس retraction around the tumor cells وبتappear as lymphovascular emboli. طبعا it's very important to identify في الحالة دي وجود endothelial cells, أو إن أنا لو مش عارفة أعمل endothelial markers. Anyways, هي حتى لو إنها lymphovascular emboli, it is still counted في cellularity, and it is still counted نعمل لها percentage, and it is still counted as invasive foci وبنعمل لها percentage. الحاجة الثانية إن بيبقى ال DCIS squeezed between the fibroblastic stroma, and it mimics إنها تبقى ال invasive component that we see on the right side. أنا مش عارفة الماركر أنا عملت إيه؟ أوكي ماركر فين؟ هنا. You can see them squeezed by the fibroblastic stroma. في الحالة دي لو أنا شاكة إن دول DCIS, it's very important إن أنا أعمل marker and I confirm, لأن الحالة دي هتفرق من pathological complete response لحالة فيها. If I have any doubt, have a low threshold in performing immunohistochemistry. These are the easier ones. When you have complete response, the tumor completely disappears, replaced by fibrous stroma, hyalinized stroma, vascularized stroma. ممكن inflammation, macrophages, and so on and so forth. This is another example of complete response where you have only acellular mucin. It is still considered as pathological complete response. When you have no cells within the mucin, it is still considered as pathological complete response. كده احنا خلصنا كل tumor bed. We go to the lymph nodes. في شوية precautions when we examine the lymph nodes بتاعت ال post neoadjuvant. واحد, it is very important زي ما قلنا الكليب في السبيسيمن الحقيقيه, في السبيسيمن الاصليه, الكليب اللي ممكن يكون محطوط برضه في الليمف نود is very important, لان sometimes the lymph node vanishes ويبقى في مكانها الكليب. فاذا هم they inserted the clip and you know they inserted the clip, you have to look for that clip and document that the lymph nodes with the clip is is excised in the specimen. الحاجه الثانيه انه sometimes it's very difficult to reach 10 lymph nodes. And it is acceptable. يعني sometimes we only find 9, we only find 8, and it's still acceptable post neoadjuvant إن أنا ألاقي أقل من 10. However, لما بيبقى كده, you go back to the specimen and take every fibrotic element or fibrotic tissue around any blood vessels you take, you will find some small lymph nodes نكمل بيهم ال10. الحاجة اللي مهمة جدا, and I really would like to say that the intraoperative evaluation بتاع حالات البوست neoadjuvant is very very challenging, and the rates of false negatives particularly touch imprints is very high. But be very very cautious when you're doing intraoperative evaluation for that. It's not very reliable. Rates of false negatives are very high, لأن the rate of presence of isolated tumor cells and microfoci is very high in these lymph nodes. فبالتالي يعني I'd rather not rely on that. حتى الفروزن sections الفولس negativity فيها عالية, particularly with lobular carcinomas. given all of these challenges, you should have a very, very low threshold in using immunohistochemistry in identifying foci in the lymph node. بمعنى ان لو عندي particularly، ودي بنشوفها كتير قوي في حالات اللوبيلر كارسينوما and we always order immunos. لوبيلر كارسينوما واخده تريتمنت وكلها تريتمنت افكت، بس انا شايفه very very tiny foci كده انا مش متاكده منهم هل دول atypical cells ولا clumped cells فوق بعض. I would always do immunohistochemistry and confirm by pan-cytokeratin and confirm the presence of tumor cells. أنا هتفرق قوي قوي هنا إن أنا أقول له إن دي complete therapy response وما فيهاش أي حاجة، وال isolated tumor cells will preclude a pathological complete response حتى. الحاجة الثانية دي lymph node ما فيهاش any isolated tumor cells. الchallenge الثاني بقى في lymph node إنه how to measure that lymph node. According to the guidelines بيقول إنه we need to measure the largest metastatic focus، مش الليمف نود على بعضها، من measure only the metastatic focus. ولو أنا عندي multiple foci بس ما بينهم therapy effect باخدها على بعضها including the therapy effect is in في ال RCB this is how to measure. لو في therapy effect in the middle you take it all. ولكن لو ما فيش therapy effect in the middle and you have normal lymph node tissue وفي كذا nodule you take only the largest metastatic deposit. فهنا في فرق ما بين الاثنين. الايسوليتد تيومر سيلز نقدر نحطهم في الار سي بي والسايز لحد 0.05 ملم نقدر نحطهم في الكالكوليتر بتاع الار سي بي. فما نقولش ان هي لا قليله ولا دول ايسوليتد تيومر سيلز، لا نحط حتى الايسوليتد تيومر سيلز we can include them في الار سي بي. طب what is not in RCB؟ يعني احنا قلنا كل الايتمز اللي موجوده في الار سي بي. What else is not in the RCB and we still need to comment upon in our report؟ اول حاجه and it is very challenging برضو في الحالات البوست نيو ادجوفنت التي ان ام الستيج التي ان ام staging. how to measure the T، how to measure ال N. التي بالنسبه للتي لو هي تي اي اس او في كارسينوما ان سايتو او ما فيش اي حاجه خالص it is considered as a pathological complete response وبن label it as a PT0 او PTIS not PTX. PT0 او PTIS. وزي ما قلنا قبل كده ان residual DCIS does not preclude the definition of PCR. طب لو العينه فيها residual tumor والresidual tumor ده طبعا المور challenging ان انا الاقي multiple tumor foci scattered here and there وانا مش عارفه اقولها ستيج على ايه. الجايد لاينز لحد دلوقتي بتقول انه we measure the largest invasive focus and we say according to that largest invasive. لو هم scattered والمسافه بينهم بعيده مش scattered and وقريبين من بعض scattered وفي big area in between بنقول انه we measure the largest one وده بنعتبره ال T and then if they are multiple we put the modifier M جنبهم. Is this accurate and is this representative of the actual stage؟ لما هي العينه يبقى فيها 5 سلايدز عندي واحد في اول واحده وشويه في ثاني واحده وواحد في رابع واحده and then اقول ان الستيج T1B وهو مليان فيهم حاجات ثانيه. Is this really the actual stage that really reflects؟ اكيد لا. والجايد لاينز لحد دلوقتي are not really clear في الحته دي. However عشان نتخطى الكلام ده it is better to describe. يعني we have multiple foci of invasive tumor scattered around. The largest one measured كذا. لو قادرة تقولي more than one ان انت عندك 5 foci scattered و the largest one كده يبقى احسن واحسن. لكن as much as we can نوصف عشان نساعد الانكولوجيست انه يبقى عارف what is he dealing with. The presence of lymphovascular emboli برضو دي حاجة ما اتقالتش قوي. لو لقينا lymphovascular emboli هقول TA T1 ولا T هقول ايه برضو دي حاجة مش واضحة جدا لسه في الجايد لاينز. You describe يعني فده منظر الحاجة اللي أنا بقول عليها إنه this is a residual focus.
I think TX يا دكتورة مها هنا
sorry
I think TX كان زمان كانوا بيقولوا الانفلاماتوري بريست كانسر كان بيبقى TX
TX.
فاي ثينك ان احنا we should consider it as a TX لان مش قادر اقول ان هي T0 مش قادر اديلها
يعني هو في الجايد لاينز كاتبين انه it is still not clear.
it's not clear
حاليا نكتب ايه
خليها TX يعني
TX
يعني لو احنا بنتفق هنا على consensus I think TX is more يعني the most fitting يعني ممكن تبقى احسن حاجه but it's the most fitting يعني.
اخر حاجه السايز ده اللي هو this is how to measure it. الثيرابي افكت we have to document whether or not في ثيرابي افكت لانه وجود الثيرابي افكت معناها انه كان في ميتاستاسيس في الليمف نود دي قبل كده وده برضه has to do with the prognosis and the outcome. الام ستيج لو كان M1 من الاول it stays M1 ملناش دعوه. الجريد we have to also grade the tumor وساعات كتير جدا some of the tumors change their grade and this also has an impact on the prognosis and the outcome. Biomarkers, do we repeat the biomarkers after neoadjuvant therapy? الجايدلاينز بتقول if they were previously negative وما فيش response then yes we do have to repeat. However برضو it's still according to agreements في كل institution. Thank you very much.
ثانك يو دكتور مها. هو بس كان في المحاضره دي تعتبر معظمها باثولوجي شويه، بس دكتوره مها هايلايتد جزئيه كده اللي هي بتاعه الكليبنج. ده الكليبنج ده الجزء بتاع حضراتكم بتاع الراديولوجي. الكليب فعلا بالنسبه لنا بيبقى كروشيال، بيبقى مهم جدا، لان في اوقات اللي هي بيبقى يحصل فيها ميلتنج داون تماما للتيومر، انا ما بيبقاش عندي اي ايفيدنس غير الكليب اللي حضراتكم حاطينه. فالكليب ده بالنسبه لنا از كروشيال جدا. بنهتم دلوقتي كمان ان هو السبيسيمن ايميجينج، يعني بوست اكسجن سبيسيمن ايميجينج ده بيتعمل دلوقتي علشان يعني ابقى بي شور ذات ذا كليب اند ذا ماس انتايرلي اكسايزد، وبنبقى متاكدين منها بحيث ان الباثولوجي بعد كده لو لقى الكليب خلاص هو يقدر يتعامل براحه تامه ان الكليب موجود، معنى كده ان التيومر اتشال، معنى كده ان المارجنز ار يعني I can depend on the margins of this specimen. لان لو ما عندناش الكليبنج اللي محطوط متصور وحد مثلا ان اكسبرت باثولوجيست دخل وقطع الحاله وما عملش ريبورتنج للكليبنج، بنرجع بعد كده نسال طب كان فيها كليب ولا لا اصل انا مش فاكر، اصل انا مش متاكد، اصل كان فيه وقع. فبندخل العيانه في دايلما هل التيومر فعلا اتشال ولا لا، سبيشالي في حالات الباثولوجيكال كومبليت ريسبونس. فتسلم ايديكم طبعا على الكليبنج الاولاني، وتسلم ايديكم على البوست سيرجيكال اكسجن ايميجينج. ودكتوره مها بقى.
Thank you, Dr. Maha. Now let's move to our next speaker, Dr. Mohammed Zaqoub. Dr. Mohammed is a lecturer of pathology at National Cancer Institute and a consultant pathologist at Bahia Hospitals. The floor is yours, Dr. Mohammed.
Thank you, Dr. Mahtab. Welcome everybody. Assalamu alaikum. Okay, pointer the pointer. Okay. We will be talking today about nipple discharge cytology, mainly focus on papillary lesions, which is the most alarming finding in nipple discharge. Okay. This is a quick review of what we will cover today: instance and causes, indications, techniques, and some of the classification systems we are using in the assessment of breast cytology, some case presentations, summary, and recommendations. The nipple discharge is a common presenting complaint in breast clinics, about 5 to 10%. It's either physiological, which are mostly will be from bilateral, from multiple ducts or multiple openings, lactation related, or hormonal; pathological, which will be usually from a unilateral and from a single opening and likely will be bloody. The common causes mostly benign as fibrocystic changes and ductictasia, and however, there are about 3 to 20% are linked to carcinoma. What are the indications? The presence of a spontaneous discharge, unilateral discharge from a single duct being bloody or serous, and the persistent discharge in patients over 50 with high clinical suspicion like family history and others. How is the sampling? It's not like the fine needle, and it needs just very few tips: gently massaging the breast in the direction of the nipple. If it's not spontaneous, if it's spontaneous, it's fine. If it needs a little bit of like squeezing or massaging of the breast, not pinching, I'm just like making some massaging. So I am pushing the fluid to the opening, and by the slide on the tip of on the nipple, and just very, very slow and very slight smearing over the nipple. I don't need smearing slides over each other like the usual fine needle unless it's abundant. And then as well, avoid pressure on nipple because it will lead to a lot of squamous cells, which may obscure the actual material that I would like to examine, and will be full of squamous cells and anucleate squames. Slides, according to, and it's preferred that I use two stains, the Papa Nicolau and one of the Romanovsky or air-dried smears. So part or most of the material will be immediately fixed in ethyl alcohol, 95% or more, and like one or two slides to be air-dried and then stained with one of the Romanovsky family of stains. What are the key questions to be answered during the sample? By the patient, I'm asking about duration and the color of discharge, because sometimes the patient will tell that it has been present, for example, for 3 months, it stopped, it's back again. And relation to pregnancy, menstrual cycle, and the lactation, menstrual cycle regularity. By the aspirator, the most important is color of it and the number of openings. And in number, for example, it might be multiple, but it could be bloody from just one opening. So this should be documented. It's not bloody, it's not multiple in this way. It's from a single opening. And the presence of lump or absence, and surface erosions, because if there are surface erosions, I will go for scrapping cytology, because actually when there is finding like this, it would probably be Paget disease of the nipple. And for decoding of nipple color discharge, the clear is mostly in ductictasia, milky in breastfeeding, yellow infection, green fibrocystic, brownish fibrocystic whomever ductictasia. However, the brownish might be representing old hemorrhage, and the bloody is the most alarming color. In these examples, these are multiple, but the one on the left, there are two like grayish and one bloody. The other one are multiple, but all of them are bloody. This is another one. When I am examining, it might be spontaneous, doesn't need to be any squeezing, and sometimes it needs to be pinched off even by the patient. The patient says that, no, it's just with movement, it's just with pressure, or I find my clothes are wet from the discharge. There's no specified or there is no specific classification system for nipple discharge. All what is present are for breast fine needle cytology. So there is nothing specific. Even in the Royal College pathologist guidelines datasets, it documents that we can follow that of the fine needle reporting categories C1 to C5, as we all know, but they prefer to call C3 as a TP of undetermined significance in case of the nipple, because this category would have less or lower rate of DCIS than the conventional breast fine needle. And to the right are the usual criteria that we will be looking at from the left side, the benign to the malignant, but there are a lot, they are overlapping, and they were intentionally proposed for breast fine needle, which a bit different. In summary, the benign would be usually sparsely cellular, a lot of foam cells, monolayered ductal cells, inflammatory cells, and few RBCs are accepted. The suspicious to malignant side will be highly cellular, and signs of cytologic atypia like enlarged ductal cells, isolated or discohesive and in clusters, variable nuclear and pleomorphism, stripped nuclei, nucleoli extensively hemorrhagic, and associated necrotic debris. The other system is the IAC, International Academy of Cytology, Yokohama classification system, which belongs to the family of the Bethesda reporting system, Paris system for urine, and Milan system for salivary gland cytopathology. This one has been held in Yokohama, and it provides a standardized classification of breast FNA cytology with defined risk of malignancy for each of the category. Even this one was intended for, actually the name is reporting fine needle aspiration biopsy cytology, and there is a very small chapter at the end of the book about nipple discharge cytology, which doesn't have specific criteria. And these are the risk of malignancy for each of the categories. The inadequate up to 5%, benign is the least of them, 1.4 to 2.3 from 2 studies, and the malignant about 99 to 100%, and the suspicious as well about 80 to 90%. The 5 categories: inadequate when smears are too sparsely cellular, poorly smeared or fixed, preventing definitive cytologic ATP. And we see a lot of this in practice. The nipple discharge is very fragile. I don't have blood to maintain cellularity or the ecosystem around the cells. So if there is very few seconds of being late before fixing, every cell will be large, every cell will be degenerated and will be alarming or will be worrisome. The benign, when I find clearly benign cytology features, that, such as that of, for example, fibrocystic disease or ductictasia. The atypical are the gray zone, which actually this category it's following all the guidelines or all the systems of classification. This gray zone, either I have very few atypical cells or occasional, very occasional, that quantitatively or qualitatively doesn't progress to suspicious or qualify for suspicious and malignant. The suspicious, some malignant features are present but insufficient for definitive diagnosis, and if I am suspecting a definite type, I would document it or clarify it. Malignant, there are malignant clear features and specify type when possible. The other system is modified Masoud system. It is a modified version of the original Masoud. It belongs to Dr. Shahla Masoud, one of the pioneer cytopathologists in the USA. She is from Iran. And this modified version was published in Acta Cytologica in 2019. This system, this is the original, and these criteria are the same of the old and the new one. They examine these six parameters: cell arrangement, pleomorphism, myoepithelial cells, anisonucleosis, nucleoli, and chromatin clumping. And each of them has 4 categories, and each category has a scoring from 1 to 4. It looks like that of the Nottingham Prognostic Index for the T, for the nucleus, for the mitosis. And at the end, we have this total score: 6 to 8 non-proliferative breast disease, 9 to 14 proliferative without atypia, 15 to 18 proliferative with atypia, and malignancy 19 to 24. Actually, this teaches us to have a lower threshold, because if I don't find anything, it's 6. But if I just go to 9, it's a proliferative breast disease. So for example, if I have some nuclear overlapping, some mild pleomorphism, and mostly actually I cannot see or judge about the myoepithelial cells, so at least it will be moderate number or even few. So in this way, I am moving on to the proliferative breast disease, either with the atypia or with the atypia. It will depend on the rest of the findings. A very recent article published like 3 months ago in Acta Cytologica, it was comparing the modified Masoud scoring index, MMSI, with the International Academy of Cytology Yokohama system. They have examined the same number of cases. I think it was about 325, and they were assessed or reassessed by both the MMSI and the IAC Yokohama. And actually the findings were comparable, and it was the highest in malignant and suspicious. Here, the number of categories are different. Here, we do not have the inadequate category. Here are 5. Suspicious or malignant, 80 to 90%. The malignant there is 90. The atypical is nearly the same, and the benign is the same. This is comparison of sensitivity, specificity, PPV, and NPV, and diagnostic accuracy between the both systems. It's almost the same. There are very trivial differences we can see. A few cases for presenting. The first one is 57 years old female presenting with right bloody discharge. I'm sorry, I don't have a number of opening for this case. The radiology of this case was just prominent bilateral retroareolar ducts. And this is if we have a radiologist. Okay. And these were the only groups found in the 4 slides. So we have a spectrum of changes starting from this. This is a clumped group. It looks like a papillary frond. Here it has become less cohesive. The cells are hyperchromatic, and you may say that the pictures are not perfect, but actually this is the real scenario of nipple discharge cytology, because it's not something that I smear and I try to be clear on it. No, it's a discharge that I take, and I take it with all what is surrounding, either secretions or blood, which makes things more difficult. And this case turned it to be, so if we say, I would, for example, say this is proliferative breast disease, first of all, and maybe or maybe not, I would say atypia, because here in the one to the left corner, it has become less cohesive. I have pleomorphism. I cannot comment actually here in this, for example, about my epithelial cells, the chromatin a bit clumping, but at least I would say at least proliferative breast disease. And this turned on to be a case of intraductal papilloma with focal ADH. Next case, 27 years old female. The first was 57, but we see nipple discharge cytology alarming in young age as well. 27, right bloody nipple discharge from a single opening, and the radiology of the case was right breast localized the prominent retroareolar ducts with no gross soft tissue lesion by RADS3. And these are the groups. I'm sorry for the quality, or as I say, this is the actual. In this case, I have many papillary fronds. I think all of you would appreciate that. Here, and here as well. Here, here, here. And there is pleomorphism. There is irregular chromatin and irregular nuclear membrane. In this case, I would say proliferative breast disease with atypia. And it turned out this is, you would be very lucky if you see such cellularity in a nipple discharge cytology. And it turned out to be a DCIS. Third case, 48, left bloody nipple discharge from a single opening, retroareolar region showing multiple prominent ducts with echogenic non-vascular contents, likely inspeciated secretions. So it's not suspecting pathology. And this was the first group. It's a cluster, or I have some nuclear overlapping. I have differences in size and shape. If I could say that, for example, in this one, I have some chromatin clumping at one side. This is another one. It's very dark. It's compact. This one is like a papillary frond as well. And it turns out to be papilloma with focal ADH. It's 0.6 millimeter. This is equivalent to this, or looks like. And this was 0.75 millimeter. Fourth case, 77 years old female, left bloody. This one has left mammary retroareolar intraductal soft tissue lesion, most likely papillomas, and intraductal lesions at distance about 3 and 4 centimeters from nipple and 1 to 2 centimeters from deep to skin. This here represented that this as a photograph of a complete slide, and actually this case was having just 2 groups, and this is the usual scenario in nipple discharge cytology. You can find just 1 group or 2 groups if you are lucky. This one, cluster or has some papillary configuration. It's not important, or it is not the issue to say that it's papillary or not. I have a proliferative disease. I have some features of atypia. I'm sorry, this one. Okay. Oh. This case turned out to be, yes, this case turned out to be an intermediate grade DCIS. Yeah. The fifth case, one before the last, 68 years old female, bloody nipple discharge, radiology, regressive course of an inflammatory process, and the prominent ducts containing echogenic contents, likely inspissated secretions as well. And this was the only group in the cell. It's like a papillary frond or a clumped cluster. And this as well turned to be out a low-grade DCIS. And our last case is 35 years old. I'm sorry for the numbering. It's not working correctly. I'm sorry. 35 years old, right, viscid brownish nipple discharge from a single opening. It's just 35. It's not above 50 or anything. Revision of outside mammography, bilateral heterogeneous fibroglandular tissue with no suspicious microcalcifications or speculated masses. And these were the only two groups. This is in a higher power. One of the very important clues that I find from practice is having a cohesive groups and having dense cytoplasm. Actually, it looks like that when you see these epithelioid cells in a lymph node, fine needle, because the epithelioid histiocytes might look very similar, might look very suspicious, but degree of cohesion and cytoplasm makes the difference here as well. And this case turned out to be a DCIS as well. This is a summary of our cases. The first one, it just demonstrates that our cases were like nearly normal radiologically, with nipple discharge is the only presenting symptom, and they turned to be like 4 of them were DCIS, 1 of them, 2 of them have focal ADH. Okay, this is a single case, and it shows a spectrum of changes or a spectrum of findings, starting from, if I see this one as well, I might say that this is like a small cells. It's making a cluster or nuclear overlapping. But when you move to someone like this, the cells became less cohesive, very irregular nuclear membranes. Even if there is a degree of, there is some sort of differentiation, some sort of degeneration, yes, it's present, but the cells are still atypical. Okay, just 2 slides. There is no standard reporting system. C1 to C5 system for fine needle from the RC path and from the Yokohama is most commonly adopted for fine needle and for nipple discharge. The advantage on MMSI, it provides detailed criteria to consider a structured and objective analysis. It systemizes your mind that I'm going and or I am checking these criteria. The IOC Yokohama has a very good advantage, is having an inadequate criteria, which is essential to consider repetition. In many cases, I have asked for repetition, and the clinician might say, why do we need to repeat a nipple discharge? Actually, when I find it bloody, I find the picture is not very straightforward. For example, if I see a pathology, then I must go for repetition. That's why it is documented and it is present. Recommendations: please lower your threshold in nipple discharge cytology and don't ignore a single cluster. I am not saying to go for malignancy, but at least say it's a proliferative breast disease, either with or without atypia. Consider resampling of the discharge if you, especially if it's bloody or brownish. Don't be deceived by benign nature of the radiologic findings, and nipple discharge, as we saw in all these cases, might be the only presenting symptom. Thank you.
Thank you, Dr. Mohammed, for your informative lecture. Now let's move from papillary lesions and cytology to challenges and pitfalls of papillary lesions on the level of histopathology in a lecture by Dr. Ahmed. Dr. Ahmed, you can start.
Assalamu alaikum. The point with papillary is very challenging, and 20 minutes will not be enough for covering everything. But I will try to just address anything we can, just for pathologists. So I will go through how to make a diagnosis in routine practice if you have a papillary lesion. What is papillary lesion? Any structure with finger-like process. So you have to have finger-like process and covered by epithelium. It's called the papillary. This is opposite to micropapillary when you have similar to finger-like process but without cores. So you need to have a core to call it papillary. Micropapillary is different because micropapillary, there is no micropapillary benign except gynecomastoid and not micropapillary. Micropapillary DCS and invasive micropapillary carcinoma. However, papillary, any structure can be benign, atypical, and malignant. So remember, we have a structure and we have a core in the center and surrounded by epithelium. And this core-like process can be variable. So you can, this is a classic one, typical one, but you can have more fibrosis within the cores and in between, so making it a bit difficult. So like this one, you can have a lot of epithelial proliferation, making the cores will be rudimentary, will be very, sometimes you need immunohistochemistry or go to high power to identify the cores, like these ones. So it is, you see capillary and a little bit of stroma among the epithelial proliferation. And at the periphery, if you have fibrosis, this will be a sclerosed papillary lesion. You have entrapped of the epithelium, mimicking, invasion. And because we have EQE performance in the UK, and some of the cases that worst performance was fibroepithelial lesion and the papillary lesion. And some of the invasive, some of these cases were called as invasive carcinoma. So if you have sclerosis in benign papilloma, some pathologists called it invasive carcinoma. So this is, as I mentioned, when you have solid epithelial proliferation, look at the structure like this and search among the epithelial proliferation for fibrovascular cores. Don't count apocrine. Apocrine is not papilloma. You can have papillary apocrine metaplasia, but not a papilloma. There are some few cases in literature case report where you have apocrine papilloma, but this is a very large or circumscribed lesion. All of the lesion comprising of apocrine epithelium. But what we see in fibrocystic change is scattered ducts full of apocrine cells. When they proliferate, they mimic, papilloma, and usually you don't have cores. Or these cores would be something like supporting structure, but most of these papillary structure don't have cores. So don't overcall papillary apocrine metaplasia as papilloma, because the treatment is different. Fibrocystic change is benign, papilloma is B3 and can be treated differently. And some high-grade malignancy, sometimes you have necrosis and ischemia, and the cells will die except those around the blood vessels. So you end up with scattered structure having fibrovascular cores in the middle. But this is because of the ischemia. And these are the surviving, and this is not papillary. This is NACT triple negative high grade with necrosis. So when we review 240 cases of second opinion cases no, this is EQE. When we review 240 cases, we found that underdiagnosis, overdiagnosis was observed in 13 cases, 1-3, out of those 9 papillary. So most of the benign called malignant called benign. These are overdiagnosis, underdiagnosis. So 9 out of the 13 were papillary. So our performance is not the best, to be honest. If you look, these are examples of cases. So you have 65% called it in situ, 27 called it invasive, and 8 called it benign atypical. Another case, 70%, 22, 8, 19, 75, 6, 77, 11, 12. This is invasive, in situ, benign atypical. And 8% of 700 pathologists, how many? 50 pathologists. 50 consultants. So don't ignore. I can be one of those 50 consultants. So it's not 1 or 2. There's not a typo during data collection. No, it is a real pitfall. And even you look at these cases when they called it invasive, they didn't know how to measure the size. Some of them measured the whole area, some of them measured the. So it's very how to reach. So you have to be careful when we see a papillary lesion. Pay attention. So how to classify? So we classify based on the presence of myoepithelial cells at the epithelial stroma junction between the epithelium and the stroma. Myoepithelial cells are located. So around the papillary lesion and within the course. So this is very important. If you have myoepithelial cells at the periphery, so you have, and then look at the myoepithelial cells within the course and present within the course, it is, and no atypia, it is papilloma. No epithelium in the course, so it is papillary DCS. If you have epithelium in the course but with atypia, it's different classification, ADH, DCS, and so on. If you don't have myoepithelial cells at the periphery, this is from the start, it will go into the carcinoma. Benign usually have myoepithelial cells at the periphery. So, but so it is papillary carcinoma. Circumscribed, it will be either encapsulated or solid or pure or mixed. Infiltrative, it is invasive papillary carcinoma. So you combine myoepithelial cells at the periphery and within the course with atypia within the epithelium, both of them together, and then you can have this systematic or classification. Just to go quickly through the most common ones that we see in routine practice: benign papilloma. Central duct, usually close to the nipple, large circumscribed mass, present with nipple discharge and so on. And you can see it here. This is a little bit, you can have fibrosis, so the capsule is thickened. And it can be cystic, it can be solid. And this is the gross. You can be lucky and have something like this, which is typical of papilloma, but not all the time. If you see apocrine metaplasia in papilloma, it goes with benign. Apocrine papillary DCS or papillary carcinoma usually don't have apocrine metaplasia. If we have apocrine cells in papillary carcinoma, atypical apocrine cells, malignant apocrine cells, not benign apocrine cells. So when we see apocrine metaplasia, it is benign papilloma. When we see something like this, is this papilloma with fibrosis or fibroepithelial lesion with cystic change? So on excision, both are benign, but sometimes you have a core biopsy like this. So if it's a core biopsy, fibroadenoma is benign, papilloma is B3. So you have, look for the representative areas, the cut levels, deeper. If you get prominent papillary structure, so likely to be papilloma with fibrosis. Look for other features, what I mean. If you have excision like this, I will look at the periphery. So usually papilloma will have double layer at the periphery. Fibroadenoma are likely to have double layer at the periphery of the structure. Okay, so if you get this in a core biopsy, you will be struggling. What is this? But something like this, I can call it B2 benign. But if it is cystic on imaging, you have to consider the context as well. But the overlap, fibrocystic change, fibroepithelial lesion with cystic change, overlap with papilloma with fibrosis. And something like this, can you see fibrosis? Up to now, it's difficult. Is this complex sclerosing lesion or papillary lesion? I look at the diagnostic area like this. I think this is papillary. This is not complex sclerosing. It doesn't look like complex sclerosing lesion. So it is a complex sclerosing papillary lesion. So a case like this, I would call it complex sclerosing papillary lesion. Not complex sclerosing lesion and not papillary, only papillary. Okay, and don't worry about something like this because this is entrapped. Usually the epithelium, the malignancy, infiltrative malignant gland will have the cellular desmoplastic stroma. But when you see a regular gland in a collagenized stroma, usually is not infiltrative, is not malignant. So it didn't initiate stroma response. This is sclerosis, not desmoplastic stroma response of invasive carcinoma. Okay, similar to like this one. So look at the stroma around, it is collagenized. So it is not cellular desmoplastic. You may have something like this. This is called infiltrating epitheliosis. You can have fluorid epithelial proliferation in papilloma, and you can have focal loss of myoepithelial cells. But usually, if you do myoepithelial cells, you will find myoepithelial cells focally. It's not absent completely. And the epithelium look hyperplastic, not malignant. So focal loss of myoepithelial cells in area of extensive epithelial proliferation is not indication of being invasive carcinoma. It can be what's called infiltrating epitheliosis and is just fluorid epithelial proliferation, and since the myoepithelial cells will be attenuated. Okay, similar, can you see this area? So this is actually a case of nipple papilloma, nipple adenoma. or similar to papilloma, and this is the normal part, and look at this extension. So if you look at it without, you can call it invasive carcinoma. But when we look at myoepithelial cells, you will find the myoepithelial cells around some of this cluster, absent around the others. You know, so it is focally preserved. If it is invasive carcinoma, it will be completely lost. So focal preservation of myoepithelial cells in the same context is indication that it is benign, or at least in situ, not invasive carcinoma. If it is invasive carcinoma, it will be complete loss. Okay, in papilloma, if we see florid epithelial hyperplasia, sometimes you see mitotic figures. Don't overcall it, because I have seen some of these cases called as intermediate grade DCS. So the pitfall in when you have florid epithelial hyperplasia, sometimes you get, you know, proliferation, so you get mitosis. And the cytology is a bit worrying. You look at it, the cells a bit like looks hyperchromatic and at least polymorphic. So small, large, irregular. So don't call it intermediate grade DCS. Look for other feature, architecture. So there is no polarization. These cells are just similar to the hyperplastic process, but florid. So this is a case of nipple adenoma. When the papillary lesion in the nipple, you call it nipple adenoma. So there is no difference. The difference is the location. It's not different. It's not two entities. Papilloma in the nipple is called the nipple adenoma. It's a variant of nipple adenoma. You can have several variants of nipple adenoma. One of the variants is papillary, but it is papilloma of the nipple. Okay, but this is usually, if you get a bunch biopsy, it may the mistake or the pitfall, you call it invasive carcinoma. So be careful when you have a bunch biopsy from the nipple and you see epithelial proliferation irregular and this is either nipple papilloma like this, nipple adenoma like this with papillary proliferation and infiltrating epitheliosis like a change, or syringomatous tumor of the nipple. So don't call it invasive carcinoma. Syringomatous tumor of the nipple, you can have infiltrative glands lacking myoepithelial cells. So you don't call it invasive carcinoma. So from the nipple, be careful. Don't jump to invasion and look for other features. And if you are worried about the epithelium, just do immunohistochemistry. Hyperplastic will be mosaic ER and mosaic cytokeratin. Neoplastic diffuse ER and absent cytokeratin. What happens when you see a lot of myoepithelial cells? So when they increase, this is papilloma with increased myoepithelial cells. Can you see this area? But when it is too much increase of myoepithelial cells, you call it adenomyoepithelioma. Why? Because adenomyoepithelioma recurrence rate is higher, much higher than papilloma. So we need complete excision. Otherwise, it will come back and come back and come back. And when it comes back, it can be a lot of myoepithelial cells, and it can be atypical and. And one of the two cases actually atypical adenomyoepithelioma, they had lymph node metastasis. 2 cases in my practice. They came back with lymph node metastasis, but we reviewed the primaries, atypical adenomyoepithelioma, not malignant. So it is a bit different from papilloma. So when you have myoepithelial cell proliferation like this, just differentiate: is this papilloma with focal myoepithelial hyperplasia, or is it adenomyoepithelioma? Remember, papillary lesion associated with the highest frequency of biopsy site-related change, epithelial displacement. So when the biopsy, core biopsy, core or FNA or whatever, and then the fluid of the cystic structure of the papilloma comes with the needle track, and then initiate fibrosis, and the epithelium will be entrapped. So you have epithelium lacking myoepithelium in the area. So it mimics, sometimes it is very fluid that you call it invasive carcinoma. Sometimes you see it in blood vessels. So you call it vascular invasion. So remember, look at the primary lesion. Is the primary lesion benign papilloma? Okay, don't worry about the other one. If the primary lesion is carcinoma, it can be real. Look at the hemosiderin. Hemosiderin is very important. Biopsy site-related change will have hemosiderin. The other one will not have hemosiderin. If it is invasive carcinoma, it will be desmoplastic, cellular, so clean, not with hemosiderin. And related to the site of the biopsy. So if the lesion is here, usually the site track will be close to it, but it's quite far from it. Think it again. We had one case, medico-legal, and it was reported as invasive carcinoma, and then reviewed by during MBDT, down is graded into displacement, and then the patient was treated as DCIS. It was papillary DCIS, and then the patient developed metastasis, and the case was reviewed. And then the pathologist, the reviewing pathologist called it, no, it is invasive carcinoma. So you have one called it displacement, one called it invasive carcinoma. And because the patient developed metastasis, it went to the court. So you need to be careful that if you be careful, don't overcall and don't undercall. But papillary lesion, look at the primary. If the primary is malignant, be attention. If the primary is benign, usually it is benign. And again, you can have look at the epithelium entrapped, and this sometimes after, usually the worst one you have within 2 weeks. If you have a biopsy and then excision within 2 weeks, you get the worst one because it's very, very florid and worrying. But the more time between the biopsy and the excision, the concern will go down. The area will be fibrotic and will be, this and will be degenerating. And if you do this cytokeratin, for example, CK56, CK14, beta cytokeratin will be positive. Myopithelial cells don't do it because it will be negative. Okay? So hopefully, we will be lucky if it is gap between the biopsy and the excision is more than 3 weeks, 4 weeks. If it is too short, be careful. Can you see how many epithelial clusters and going into this is a needle track. And cytokeratin will be, as you can see, very strong hyperplastic epithelium. The other type of papilloma is multiple papillomas. It's called papillomatosis, but we don't use it's multiple papilloma. Part of fibrocystic change. Fibrocystic change. Usually you get incidental finding because it's the periphery of the breast. The other one is central, that's why you get nipple discharge or mass lesion. This one, because there is no mass lesion and no nipple discharge, usually incidental, multiple papillomas. When you see it, the main concern with this one, look for atypia. Because it can be associated with a lot of hyperplasia, so you may miss ADH. And if you miss one ADH, you may have 2, 3 ADH next to each other, it will be DCS. So exclude the possibility of DCS in multiple papilloma. This is the main, nothing else. Anything else will be easy. What about papilloma with atypia? If you have papilloma and the area of atypia within it, it will be according to the size. 3 millimeter, we don't use 2. 2 is outside, is the normal breast, we use 2 millimeter. In papilloma, we expand it a little bit because of the structure, and so it is 3 millimeter. So papilloma with area of atypia less than 3 millimeter, call it papilloma with ADH. You measure the area and it is 5, 6, 7. This is low-grade DCS. Between 3 and 4, try to push it into IDH. Okay? It's not the point of cut-off. It's the point of how to manage. And because our measurement is not accurate, it's not the same, it's not concordant. So think about the age of the patient. Do we need another surgery or not? Don't go for another surgery and radiotherapy for 4 millimeter area of low-grade change. So apply the guidelines with your interpretation, with your approach. So don't apply it blindly, I don't care, because some in UK, some they apply, I don't care, 3.5 DCS. And then the patient will have another surgical excision and radiotherapy. So this is too much. So it is a bit of applies, but if it is 5, 6 millimeter, you cannot escape. Okay? And again, you can write in the report. In the report, see that something like, don't write anything controversial as one opinion. Try to write anything controversial, anything subjective, explain the 2 sides of the argument. See that this is a case with atypia. The atypia measures approximately 3.5 or 3 something, or slightly larger than. However, in view of the distribution and the architecture, and this case is best regarded as ADH. So I mentioned this and my opinion. And if you are worried about some other pathologist will review and change, ask your colleague, put other name. So this is what I do in my practice. I write, this is a difficult case, this is unusual, it shows overlapping feature, it shows this and this and this and this, I write, and at the same time, the other argument, it shows this and this and this, my opinion is this, I discussed with my colleague and our opinion, and he agrees with me. Okay, so explain in the report, just if something happened, you are protecting yourself. But at the same time, the final diagnosis will be for the best of the patient. Okay? So if you have high-grade atypia in papilloma, it is DCS. You don't measure 1 millimeter, 2 millimeter. If it is really high grade, not intermediate grade. Intermediate grade, this is the one you need to show 1 and 2 of your colleague, because it is subjective. What you call intermediate, I will call it low, and someone else will call it intermediate, and so on. So intermediate, subjective. High grade, easy, because all of us will agree on high grade. All of us will agree low grade, all of us will agree high grade. When it is intermediate, pay attention. Look at the architecture, the size, you know, as a mitosis, do immunohistochemistry. So don't jump to intermediate grade DCS without other supporting features. Say that if someone else reviews this case and call it low grade, what's going to happen? Or hyperplasia or whatever, because intermediate grade and hyperplasia can overlap. So if I am in doubt, I can use immunohistochemistry. So this is, for example, how to measure something like this. So I can use immunohistochemistry and take from the area, for example, beginning of loss, this is cytokeratin. Beginning of loss of cytokeratin, for example, this area, I will measure this area up to, for example, here. Okay, so measure the area, it will be easy to measure the area based on cytokeratin or ER. And if you have something like this, you can have partial involvement of DCS. So you can have area like this. This is papilloma, benign papilloma, and this is solid part of DCS. So it is easy to compare. You can have solid architecture, you can have cribriform. Cribriform easy. Solid is difficult. In a case like this is solid, mainly solid. So I would be worried. In this case, you can use immunohistochemistry. If it is cribriform architecture and very well polarized, I'm happy that it is DCS. But in an area solid structure like this, immunohistochemistry will be the clue for the diagnosis. I think that time is because
Another 1 minute.
I have plenty of things to discuss. Okay. So for something like this, when you measure, this is DCS. So this is, for example, you have this is papilloma, and you have solid epithelial proliferation within it. And so I measured from here to here. So this is about 6-8 millimeter. So this is intraductal papillary lesion. I don't call it papilloma. Papilloma is benign. Don't call it intraductal papillary lesion involved by low nuclear grade DCIS. The DCS measures, don't measure the whole papilloma. The DCS measures 8 millimeter, 6 millimeter. And measures the margin to the DCS, not to the papilloma. If the margin is more than 2 millimeter between the DCS and the, so it is completely excised. Okay. Again, immunohistochemistry can be helpful. I'll stop at papillary carcinoma because it is, and this is very difficult, and a lot of discussion in the WHO book about how to define papillary carcinoma and what is high grade, when it is high grade, and the papillary and encapsulated papillary carcinoma, solid papillary carcinoma, and now just I'll tell you the names. So you have papillary DCIS, when it is DCS but papillary, as part of any type of DCS. When you have encapsulated papillary carcinoma in situ, or encapsulated papillary carcinoma without any qualification. When you have solid papillary carcinoma in situ, solid papillary carcinoma invasive, solid and encapsulated papillary carcinoma associated with area of invasion next to it. And when you have invasive papillary carcinoma in the OS. So you have 6 types now of papillary carcinoma in situ and invasive. Differentiation of these subtypes needs a little bit of especially the concern comes from encapsulated and solid because they are lacking myoepithelial cells. So the distinction between in situ and the invasive is based on the morphology, not based on myoepithelial cells. So if it is well circumscribed and you can draw a line around it, it is in situ. If it starts to be invasive and infiltrating and you are going to invasive. If it started to be jigsaw pattern, like clusters pushing each other, this is not in situ. Imagine DCS is intraductal, within the duct. But invasive, when you have a complex architecture, like jigsaw pattern, complex architecture, this is not intraductal anymore. So something like this, lacking myoepithelial cells, you call it invasive carcinoma. Okay, and encapsulated papillary carcinoma and solid papillary carcinoma lacking myoepithelial cells should not be high grade. So if you have a circumscribed lesion, because triple negative can be circumscribed, HER2 positive can be circumscribed. So not all circumscribed because and the large lesion circumscribed, you will see papillary structure within it because entrapped structure, entrapped stroma. It's not papillary, it's entrapped stroma. So when it is high grade or triple negative or HER2 positive, this is invasive carcinoma mimicking encapsulated papillary carcinoma. I'll stop here because of
Thank you, Dr. Ahmed. This is one of the most debatable and controversial topic in breast pathology ever. But I think You put us on the track. Thank you, Dr. Ahmed. And now for the next session by our eminent cytopathologist, Dr. Mona Al-Abraq, consultant of pathology and at Bahia Hospitals and consultant and lecturer of pathology at National Cancer Institute, Cairo University. The stage is yours, Mona.
Today I'm going to present rapid on-site evaluation rows. Okay. أنا قصيرة. النهارده هنتكلم عن موضوع كده اسمه روز rapid on-site evaluation basics tips and tricks. المفروض المحاضرة دي أنا محضراها للباثولوجيست والراديولوجيست together. خلاص، وكمان احيانا الاندوسكوبست. فيعني اعذروني في كلام هتلاقوه اوريدي انتوا عارفينه، في المفروض لو حد تاني راديولوجي او اندوسكوبست مش هيبقى عارفه، فيعني انا عاملاها كده لينا كلنا يعني as a team. هو the definition of a rose is microscopic evaluation of biopsy passes. هي حاجه كده بنعملها live during the biopsy performance، والجول بتاعها ان احنا نوبتمايز the procedure and guarantee adequate material عشان ندي accurate diagnosis. الchallenges في الفاين نيدل في العموم وسبيشالي لو image او endoscopic guided biopsy ان دايما اللي بيسحب العينه، احنا سحب العينه بتاعت الفاين نيدل يا اما بتبقى guided فده نون باثولوجيست اللي بيسحبها، يا اما بتبقى جايدد فاللي بيسحبها راديولوجيست او الجايدد نون باثولوجيست، ولو فري هاندد بيبقى باثولوجيست. ففي كلتا الحالتين احنا محتاجين اكستنسيف اكسبيرينس. والمشكله الثانيه اللي بتقابلنا نوعيه الليجن اللي احنا بنقابله عشان نسحبه فاين، لان لو هو ليجن مش تشالنجينج او ينفع يتسحب كور فالطبيعي الناس بتتوجه للكور لانه مور انفورماتيف واسهل في السحب ويعني وكده يعني. تمام. التشالنجز على مستوى الليجن خلاص الاكسبيرينس احنا عارفينها. الليجن ممكن يبقى السايز والسايت والتايب. السايز لو سمول طبعا the smaller the nodule the higher the non-diagnostic rate. السايت لو هو near major vessel او intra-abdominal ده ممكن يبقى فيه طبعا الصعوبه ان احنا بنترانسفيرس كذا حاجه يديلي contamination برياكتيف سيلز، ممكن يعمل misdiagnosis مثلا مع well differentiated adenocarcinoma. التايب of the lesion especially the cystic lesion generally has relatively low sensitivity and specificity. في الحالة دي لو احنا عندنا cystic lesion اي حد بيسحب باثولوجي او نون باثولوجي please go to the periphery. انا المية اللي هسحبها تمام وهاخدها وكل حاجة بس it's not that informative. لو سمحت لو لقيت cyst وتقدر تسحب من الوول نروح عند الوول go to the periphery. واحيانا بيبقى لو انا on site بيقول لي انا ساحب من الوول، بقول له لا انت مش في الوول، نطلع بره اكتر go to the periphery more. اللي عندك ده ما هو الا سبتيشن، انت تخيلت ان هو الوول وده مش ده سبتيشن، ده مش الوول. فساعتها الروز بيجايد جوه البروسيجر نفسه الموضوع. طيب انا عندي الاكزامبل الكبير والدايلما الكبيره الثايرويد، هو اكزامبل رائع للتشالنجز بتاعت الليجن. هي فاسكولار tend to be hemorrhagic، هي frequently cystic changes. دايما في البناين انا عندي cystic changes، فدايما المشكله الثانيه اللي بتقابلني النوديولز may be small. احيان كتير مش بنمشي على الجايد لاينز، يعني المفروض التايرات بنبقى ماشيين التايرات لو 3 يبقى 2.5 فوق 2.5، لو تايرات 4 فوق 1.5. actually this is not the real practice. فبنلاقي مثلا تايرات 4 واحيانا بيبقى دي كيسز حقيقيه بنبقى قاعدين نص ملي سوري نص سنتي او اقل، واللي هو تصرفي وانتي قاعده معانا ويلا بينا. فبتبقى تشالنجينج جدا. فنو وندر يعني. وطبعا احيانا طبعا جنب فيزل، فلو سمحت يا دكتوره منى مش عايزين ندخل تاني احنا جنب فيزل. فيعني ساعتها انا بشوف انا وضميري والحالات يعني. طيب احنا بقى اللي بنعمله في الروز ان احنا بنتيم اب مع يعني الروز باي ذا واي. الروز انا شخصيا لو بسحب الحاله فري هاندد انا بعمل لنفسي ايفالويشن، انا بيبقى معايا ميكروسكوب جوه اللاب وكل حاجه، بس ده مش محتاج ان انا ارتحل واخد الايكويبمنتس بتاعتي. بس احنا عاملين الروز بقى لان انا خدت اشيائي وطلعت بره ومع تيم تاني، فايم تيمينج اب مع النون باثولوجيست عشان to overcome these challenges. طيب النون diagnostic rates without rows بتوصل 20% واحيانا اكتر حسب المؤسسه، حسب الاكسبيرينس، حسب البراكتس. طيب الروز بيقلل النون diagnostic rate من 10 up to 2%، يعني ويمكن اقل كمان حسب طبعا برضو البراكتس. البروز ان انا عندي جوه الموضوع لو انا قاعد خلاص I don't have to ان انا اقول له نون دايجنوستيك، لا انا وانا قاعد لايف بديله الفيدباك. ف we avoid the repetition وبيست عليه الكوست بقى للبيشنت، للنون باثولوجيست، للمستشفى، للمنظر، للاحراج، كل الكلام ده. المشكله بتاعته انه في الاخر increase the pathology lab cost لانه هو محتاج personnel. طيب الروز كده من الاخر during the biopsy is like it's equal to the frozen section during the surgery. الروز بنستخدمه في كذا حاجه زي ما قلنا، في الفاين نيدل لو فاين نيدل ايمج جايدد، لو اندوسكوبيك الترا ساوند جايدد برضه فاين نيدل. بنستخدمه كامبرنت سيتولوجي. الامبرنت سيتولوجي نفسه يا اما على الكور بس this is بصراحه مش حلوه، او امبرنت سيتولوجي بالاكسجين بايوبسي، وساعتها ده بيبقى كومبايند جوه الفروزن ادجنكشن مع الفروزن. طيب الثياتر بريباريشن، يلا get your things بقى اللي احنا محتاجينه عشان نحضر اي مكان مش باثولوجي لاب ونروح نرتحل ونقعد معاهم عشان نسات الثياتر. this is الصوره اللي موجوده دي، ايوه دي لايف، دي انا جايباها، دي برضو اللي باخد الميكروسكوب الحلو. لازم هاي كواليتي ميكروسكوب، لازم ما ينفعش اخد الميكروسكوب النص اللي انا مش هشوف بيه كويس، لان انا قاعده يعني انا محتاجه ادي فيدباك ما فيهوش كلام. محتاجه ديسك، لانه اكشلي كان في فتره ما، بص حضرتك البتاع اللي بتجر الفضي دي احنا حاطين لك عليها الميكروسكوب، ما فيش ديسك. ف we need to have a normal disk. بنسل، البنسل مهم جدا وما ببتديش شغل من غيره، علشان انا بيبقى عندي سلايدز كتير كذا حاله ورا بعض، فلازم each سلايد نعلمها بالقلم الرصاص. على قد ما الموضوع seems تافه على قد ما هو مهم جدا، لان السلايدز ممكن تدخل في بعض very easy. طبعا النيدل والسيرنجز والسلايدز والكونتينر والفيكستيف وستيننج رياجنت، ولو انا احتماليه ان انا هحتاج مايكروبيولوجيكال ستادي فساعتها انا محتاجه ستيرايل كونتينر اللي هو هيبقى عاده الكاب المفتوح اللي هو بيتفك من الغلاف بتاعه. طيب نيجي بقى عند المرحله بتاعه السامبلينج فور ذا سمير. السامبلينج اوف ذا سمير اللي بيعمل سامبلينج اوف ذا سمير في الحاله العاديه يا انا يا الباثولوجيست يا النون باثولوجيست، سواء بقى اشهر حاجه طبعا الراديولوجي هم اللي بيعملوا. فانا هبتدي بالخطوات اللي احنا بنعملها. اول حاجه انا قلت لهم يا جماعه انا محتاجه كذا وكذا كذا وثياتر بريبيرد. دلوقتي بقى هنبتدي على السامبلينج. اول حاجه choice of the needle، على قد ما هي basic على قد ما هي مهمه. احنا عندنا في تو نيدلز، في الانستيزيا سباينال انستيزيا نيدل، ده اوريدي احنا لازم نستخدمه لما يبقى الليجن ديب. انا ما عندي حاجه ليجن ديب، فغصب عني لازم اللي هيدخل لازم يدخل بسباينال انستيزيا. الجيج بتاعه عاده بيبقى اللي هو 22، عاده الجيج اللي هو لونه اصفر. تمام. الراديولوجيست لو هو طب لو انا في سوبرفيشال خلاص انت حر بقى، اختار اللي انت عاوزه اللي ايدك بتستريح عليه. طيب النيدلز العاديه بقى بتاعتنا السرنجات والنيدل، طبعا لو سوبرفيشال فالسوبرفيشال في الحاله دي يا محسوسه وما فيهاش مشكله فساعتها الباثولوجيست هو اللي بيسحبها، يا اما الراديولوجيست، وده برضو هترجع زي ما بنقول حسب الاكسبيرينس بتاعته وبتاعت ايده ايه اللي يطلع ماتيريال معاه. السيرنج اوتوماتيك، انا في كل عينه روز لازم بفك سيرنج، يعني هو خلاص في سيرنج اتفك. ليه؟ لان السيرنج ده هو اللي انا بجيب ميه الماتيريال اللي طالع لي، سواء كان في النيدل نفسها يا اما كان موجود معايا في النيدل بتاعه السباينال، ودي اللي بطلع بيها باكسبل، بملاها على الاخر وباكسبل الماتيريال على السلايد. في فترات كده جربت ان انا اكسبل الماتيريال بالتروكر نفسه بتاع السباينال، actually it wasn't good. هي كانت كانها ميني كده، ما حصل الاكسبانشن ده بيديسبيرس السيلز، فما بيخليهاش سيتولوجي، بيخليها كانها كور وبفضل اعمل كراشنج. فنتكر موضوع السيرنج دي كده كده هتتفك. طيب معلش الحركه السرنجه اللي معانا دي اللي هي ليها بيفوتد هيد، بالاكسبيرينس بتاعي بصراحه انا ما حسيتهاش ان هي كويسه خالص. السيرنج دي عشان نربطها وعشان نفكها وعشان نعمل بوزيتيف يعني نكسبل بيها الماتيريال بصراحه بتبقى فاشله جدا. واكشلي لما حد بيمسكها عشان يعمل بيها نيجاتيف سكشن عشان الخطوه اللي هقول عليها بعد كده السيل بلوك، بتبقى يعني ما بتديش نيجاتيف سكشن كويس، والراديولوجيست بيفيل بسبب بس السيرنج. فاختار نوع النيد اللي انت عاوزها، بس بليز السيرنج دي بلاش. اوكي طيب نيجي بقى عند السامبلينج. انا وانا بعمل السمير انا مش عاوزه كتير للاسف. في كده معلومه عامه انه the more اللي هو الراديولوجيست، طبعا الباثولوجيست عارف هو عاوز ايه، بس الراديولوجيست طبعا اللي هو ده انا جبت لك بتاع كتير اهو شوفي، لا actually less is more. ففي السمير less is more. انا محتاجه على كل سلايد حوالي نقطتين، اكشلي نقطتين فيهم البركه، هيجيبوا لي الماتيريال مفيش بلاد حواليهم مفيش اي حاجه، انا محتاجه نقطتين. فلما نيجي نسحب بليز دونت دو نيجاتيف بريشر بالسيرنج، اعمل شيرنج. الشيرنج لوحده مع طول النيدل هيطلع لي ماتيريال بالكابيلاريتي، مش محتاجين نعمل اي نيجاتيف بريشر. اكشلي احيانا بالذات جوه الثايرويد دي طريقه لقيتها حد استخدمها وكانت رائعه. التروكر ما بيطلعش كله، يعني السباينال نيدل بتبقى موجوده مجوفه وجواها تروكر. التروكر اول ما بيدخلوا في الليجن بيطلعوا، لا بقول لهم سيبوا التروكر الطرف بتاعه يبقى ستيل موجود، سبيشالي في الثايرويد. طبعا الاكسبشنز موجوده في الليمف نود في كل حاجه، بس بما ان الثايرويد هي اكتر حاجه بنتعامل فيها بقول لهم سيبوا التروكر طلعوه، بس ما تطلعوش كله. بيطلع لي الماتيريال حوالي مثلا 3 4 دروبس بس فيهم السبيرز، فيهم كل حاجه. السميرنج طبعا دي انا عارفه ان الباثولوجيست عارفينه، بس لو في حد راديولوجيست حاضر سيمبلي احنا بنسلايد الماتيريال عليها زي ما قلنا 2 to 3 دروبس، بنسلايد الماتيريال عليهم وللاخر ما بنخافش ان هي تقع to fall off from the slide، لانه عندهم دايما ايه، لا الحق قبل ما الماتيريال يقع ويروح شادد. فلما بيشد بيعمل منظر كده، منظر زي اللي موجود هنا في النص، اللي في النص كده، ده بيعمل كلامبنج للماتيريال. فبدل ما هي مونو لايرد لا في عندي 3 لاير في حته واحده، فالماتيريال بعد ما كان حلو شال الجزء ده عمل كلامبنج ده خلاني ما اعرفش اشوف مع ان الماتيريال حلو. فبمنتهى البساطه 2 to 3 دروبس حطوه بنكسبل الماتيريال، سواء انا سواء الراديولوجيست سواء النيرس اللي مع الراديولوجيست، اكسبل سلايد للاخر وحط في ساعتها بقى في الفيكستيف. خلاص beware of the hemorrhagic smear. لو احنا طلعنا ماتيريال اكتر مفيش مشكله، مش لازم 2 سلايدز، بنوزعهم على سلايدز كتيره عشان احنا اول ما يبقى فيه hemorrhagic ماتيريال انا مش شايفه حاجه، انت جبت لي دم فشكرا. طيب الفيكسيشن، احنا كباثولوجيست عارفين الديف كويك، فهنعمل دراينس اوكي من 1 to 5 minutes، وبعد كده هنثبت هنعمل فيكسيشن جوه الالكحول بتاعنا اللي هو 95 ل 99%. تمام. ولازم انا ساعتها بعلم على الشريحه دي انه او بصبغها وات ايفر، لان انا ليتر دي بستخدمها في الصباغه، فخلاص انا عارفه ان دي الديف كويك بتاعتي. بس في العموم لو حد مش عارف البراكتس يبقى اوتوماتيكلي احنا بنستخدم بنحفظهم كده immediate fixation في كحول، كحول 70% لا كحول 95 99. ايثانول is better than ميثانول، بس الميثانول اسرع، فيعني لو حد مزنوق وبيتزنق جامد ممكن ميثانول، بس الايثانول is better than ميثانول. علشان ده في الاخر هنعمله بابا نيكولاو ستينج. الفيكسيشن بيبقى والله قريتها كتاب 15 دقيقه، بس طبعا احنا لازم نشد شويه عشان مش عارفين، فمينيمم من تلت ساعه ل 30 دقيقه، ولو قعدنا اطول ما فيهاش اي مشكله عادي، ممكن نبيتها باليوم واليومين ما فيش اي مشكله، مش هيحصل مشكله فيها. وبعد كده بنطلعها وبترانسفير الحاجه جوه بلاستيك كونتينر ما فيهوش كحول. ليه؟ لان في مشكله كان في فتره ما هم فاكرين ان احنا عشان نحافظ على الماتيريال فبينقلوه جوه الكونتينر بالكحول. طبعا ده الترانسفير ده بيوقع الكحول في الكونتينر وبيبهدل الليبل وهو ملوش لازمه. ما دام انا اديته enough time for fixation يبقى تمام. under fixation by the way بتعمل dryness وبتخلي الخلايا ما تاخدش صبغه فبتبقى بهتانه جدا. طيب انا بقى قاعده في الثياتر هعمل ايه؟ هنقي شريحه، هختار شريحه كده it seems يبدو فيها اتوسم فيها ان فيها ماتيريال اوكي، وبعمل لها اكسبشن ان انا مش بقعدها الفتره دي كلها جوه الالكحول، لا بثبتها وقت اقل وانا مضحيه بيها. بس لما انا بثبتها خلاص انا عارفه ان هي دي اللي اتثبتت، وبرده بعلم في اللاب عليها ان يا جماعه الحاجه دي خلاص ثبتت واتصبغت، عشان في ناس او بعض التكنولوجيست ما بيبقوش واخدين بالهم ان هي اتصبغت او في وسط الدوشه، لا بعلمها لهم ما تصبغوهاش تاني. طيب الستينز يوزد في الروز طبعا ديف كويك اشهر واحده، وفي ناس بتستخدم H&E وفي ناس بتستخدم دولدين بلو وفي ناس بتستخدم هيماتوكسين. انا بستخدم هيماتوكسين. احنا في كذا حد في الاكسبيرينس بتاعنا بيستخدم هيماتوكسين اونلي. الديف كويك ميزه ان هي خلاص كومبليت ستين على بعضيها في خلال 15 ثانيه او يعني دقيقه انا عملت صبغه كامله وماتيريال كامل. بس المشكله انه لو انا مش متعوده على منظر الخلايا، لانه طبعا هي معتمده على الدراينس، فالدراينس بتكبر الخلايا. لو في مالجنسي بيحصل انه لو في مالجنسي ممكن الخبطها مع ممكن الخبطها مع مالجنسي. الهيماتوكسرين انا بستخدمها ان هي بتولي النيوكلير ستين، وبعد كده ما بحطهاش ريفكسيشن، مش بعمل لها ريفكسيشن، يا دوب خلاص شفتها وبخليها على جنب وما برجعهاش كحول. لو رجعت الكحول بتبوظ. طيب انا بدور على ادكوسي، ولو قدرت ادي preliminary diagnosis تمام، وبعد كده بعمل ترياج. الترياج ده بيست على ايه؟ طبعا قبل ما يعمل كده لازم انا ابقى واخده داتا مظبوطه من الراديولوجيست، السايت، السايز، الحاله مسحوبه تاني دي تكرار ولا ايه، كل المعلومات لازم تبقى عندي. طيب الادكوسي طبعا لو انا شفت تيومر سيلز تمام، لو انا مثلا شايفه انفكشن او مايكرو اورجانيزم تمام. طب انا هقف عند المرحله دي؟ لا انا مش هقف عند المرحله دي، انا ساعتها ببقى خايفه من اندر سامبلينج مثلا، فانا بكرر السحبه. لو مالجنسي هتكرر السحب عشان اخد مثلا سيل بلوك ماتيريال او واتس ايفر عشان اعمل انسيلري تكنيكس عليه. طب لو هي فري اوف مالجنسي باخدها عشان اتاكد، بدخل مره واثنين مثلا كمان مره، يعني حوالي 3 مرات توتال عشان اتاكد ان مفيش كو اكزيستنج مالجنسي. الترياج بقى بيست على انا شفت ايه. شفت حاجه نيو بلاستيك مثلا ونون هيماتولوجيكال، ساعتها ببروسيد على السيل بلوك. لو حاجه هيماتولوجيكال ليمفوما او شكه في كده، فلو سايتومتري، مايكروبيولوجي او nothing. الفلو هنتكلم عنها. الفيكسيشن انا بستخدم ايه عشان افكس للحاجات اللي باخدها للانسيريال تكنيك؟ فورمالين حلوه جدا للاميونوسايتوكيمستري. طب لو ثبتها في حاجه اسمها ايثانول ميثانول، ده كويس جدا موليكولر تيستنج، فحسب انا عندي في الفاسيلتي بتاعتي هعمل بيها ايه، موليكولر ولا اميونو. طيب في حاجه بنمكس الكحول مع الجليش الاسيتيك اسيد فبتدوب لي البلادي ماتيريال، وفي حاجه عشان لو فلو سايتومتري روزويل بارك ميموريال انستيتيوت، ده بنبريزيرف، دي ليها باس لوحديها. طيب السيل بلوك عندي هو ماينوت تيشو فراجمنت، بنستخدمه immunocytochemistry، اركايفال تيشو، ممكن في الموليكولر تيستنج، وبنعده كنص شريحه عشان بالنسبه لنا سيبس كاتبه ان هو يعد كنص شريحه. نعمل سيل بلوك بس لوحده؟ no it's not a standalone technique خالص. السيل بلوك complementary كل حاجه. smears can be standalone method، بس السيل بلوك cannot be a standalone method لان زي ما قلنا it cannot say it's invasive or not، وما عندناش morphology كويس. طيب في طريقتين للسيل بلوك عندنا وودن نيدل واش وسيلف كلوتنج تكنيك. النيدل واش لو انا كل مره بدخل فبواش الماتيريال في يا اما السيل بلوك بريباريشن او السوليوشن تاني اللي قلنا عليه، وده اليلد بتاعه سلو، بس احنا كل باس بنستفيد منها. او عندنا حاجه اسمها سيلف كلوتنج تكنيك، دي افضل بس دي ليها محتاجين نعمل باس لوحديها عشان نعمل سيلف كلوتنج تكنيك. تمام. احنا بروسيسنج هي ذا سيم بتاع السيل بلوك، فاحنا محتاجين دبس، دي هنعديها عشان قربنا. ده الكميه المعقوله ان احنا نعمل سيل بلوك، دي كميه فيها دبس نقدر ان احنا نمبات في بارافين، نقطع، نعمل سكشن. طيب هنعمله ازاي؟ دي من اخر الشرح، انا قربت اخلص. سيلف كلوتنج، هندخل نفس دخله الفاين نيدل، بس هنزود عليها ان احنا هنركب سيرنج في هنركب سيرنج وهنعمل نيجاتيف سكشن. وانا في اللقطه دي انا كنت قلت less is more في السميرز، more is more في السيل بلوك. انا محتاجه بلاد، البلاد ده حوالي 1 to 2 ملي، يعني هيوصل لي معايا ثانيه واحده انا قربت اخلص خالص. هيوصل معايا 1 to 2 ملي، يفضل يسحب لحد ما انا اشوفه في السرنجه. اوكي، هنعمل زي ما قلت، وبعد كده ما هيديهولي هسيبه يكلوت حوالي دقيقه او دقيقتين. القلب من اللي جوه البلود هيساعد ان هو يتجمد، ساعتها اسحب فورمالين. يستحسن ان انا ما اسحبش فورمالين بعديه على طول، الفورمالين القلب مش هيلحق يكلوت، لكن ده هيطلع لي كلوتنج وهيطلع لي شيء جامد يدخل يبروسيس على طول من غير ما يحتاج ان هو في المعمل يعمل سنترفيوج. ده المنظر بتاع السيل بلوك. ففي الاخر احنا هنعمل ايه؟ سيمبلي اسبريت ذا سمير، ويستحسن تاسبريت ذا سيل بلوك. لو انا معاك روز طبعا انا بوجهك، لو مش معاك برضو حاول اعمل كده، السيل بلوك هينقذ لانه انا مش عارف الماتيريال اللي معايا. بس فهو الروز محتاج preparation, teaming up, available data, decent material. ساعتها اقول adequate ولا لا، ممكن اعمل triage محترم lead to accurate diagnosis.
Thank you, Mona. Very impressive and very informative lecture. Now going to the next session by Professor Dr. Ahmed Rakha about updates on classification and management of fibroepithelial lesions. احنا بنختار المواضيع الصعبة جدا مع دكتور عماد وبنقول له بعد كده ايه احنا عايزين تلت ساعة، فمعلش هنحاول نختصر في الوقت عشان احنا متأخرين شوية دكتور عماد. تمام، وشاكرين لحضرتك جدا. شكرا.
التوكس دي محتاجة ساعتين مش ساعة واحدة.
بالظبط.
كل واحدة فيهم.
كل المواضيع صعبة جدا.
Just fibroepithelial lesion. It is what is a fibroepithelial lesion? It is biphasic lesion. In the breast, we have several types of biphasic lesion. You can have adenomyoepithelioma, epithelial, myoepithelial. You can have fibroepithelial, epithelial, and stroma, and you can have a metaplastic carcinoma, epithelial, but different types of stroma: spindle, squamous, adeno. So this is biphasic epithelial stromal lesion. But the main neoplastic element is the stroma. And the most common one is fibroadenoma that we come across, a lot of time in our practice, and the phylloides tumor are very uncommon. But we noticed the increase in the number of phylloides tumor in recent years, and causing a lot of concern and very unusual presentation. So it's coming up like this. I may be related to COVID-19, something, I don't know. We noticed it after COVID-19 that the range or the frequency of fibroepithelial lesion is increasing, and the unusual cases presentation is increasing as well. So you get cases that you don't know what is this. It doesn't look like fibroadenoma, doesn't look like phylloides, but in between. So this is something we don't know what is the reason for this. And think about it as a spectrum, starting from very early, like fibroepithelial hyperplasia, and then enlarge, expand, and then it will be fibroadenoma. And then the stroma will be proliferating and neoplastic, and then it goes to benign phylloides tumor, and then the stroma will be, behave badly, it will be borderline, and then it will be malignant. So you can have, from the start, you can have malignant phylloides from the start, but you can have progression. And in many cases, you can see area similar to fibroadenoma and next to it phylloides. Area similar to fibroadenoma, next to it benign borderline phylloides. And sometimes borderline phylloides with malignant phylloides. So it is a group, you can see any spectrum. And it is important to look at this, look at the currents. Fibroadenoma should not recur. Why we have look at the currents extending here? Because fibroadenoma can be multiple. So if you look at literature, the excised one, the other one came back. So, or they misdiagnosed it. It was originally phylloides and they called it fibroadenoma. That's why you will have some very low percentage of cases called them as recurrent fibroadenoma. But fibroadenoma doesn't recur. If you excise, you excise. But phylloides itself can increase the frequency of local recurrence will increase gradually. And the malignancy or metastatic behavior should start from the end of borderline. Because the distinction, we are all very good in diagnosing lesion in this area, diagnosing lesion in this middle of the spectrum, in this part of, but when it comes to this area, we are not, we overlap. When it comes to this area, so we are not sure fibroadenoma or benign phylloides, we will have discordance or less agreement. When it comes between benign and borderline, less agreement. But we are very good when it is in the center of the spectrum, which is logic. And this is the look at this is the cases from Nottingham, second opinion cases. If you look at the, as we mentioned, the top is papillary lesion followed by fibroepithelial lesion. So most of second opinion cases sent to second opinion are papillary and fibroepithelial. And then you can look at the cases, for example, look at the percentage 27, 23, and then 5% for what is the tumor typing of the tumor. Is it the DCS or not? And what is Bendel's lesion and so on. And you look at the initial diagnosis and second opinion diagnosis, some of them are, you know, like benign phylloides tumor, borderline, benign malignant, fibroepithelial lesion, something borderline. So it is, and the management is completely different. And this is from the EQA scheme, external quality assurance scheme in the UK, which we have 700, average, it is 800, but participate every time about 700. So 700 pathologists participate in every single circulation. They get 15 slides, they score them on H&E. No information, no clinical data, no radiology, no clinical, no nothing, just slides. And each one report what do they think. So if you look at this case, for example, 500 could be fibroadenoma, but still 115 could be benign phylloides. This is one of the cases, benign phylloides, 190, 48, but this is not the full number. So you have, look at this, fibroadenoma, 33 pathologists, consultant. Benign phylloides, 430. But you still, borderline, 130. So 130, so majority benign, which we agree. But imagine if you have 130 called it borderline, it should not be fibroadenoma. And this is the outlier. Those are the outliers. If you call it benign, you can accept borderline, but you should not accept the other side. If you call it benign and the fibroadenoma, you should not accept borderline. If you do this, you are outlier. And the outlier is not a small number. As I mentioned, you have 33 cases here. You have, 50. And look at this one, for example, 90 cold data hamartoma, and then benign phylloides, and the complex fibroadenoma, and the benign all over the spectrum. And this is the real performance. We cannot, whatever we see onto ourselves in meeting, and we are very good. We can diagnose everything. But this is the real life. So show me where are we in this, will we be one of the majority or one of the this side or this side? But as I mentioned, when you have large number of pathologists, respect that this is challenging. So this is a case. If I ask you what is this, don't look at the table, but look at this image. So it's a bit difficult. So you have here, you have some of them called it fibroadenoma. Majority, this is fibroadenoma, but some of them called it papillary lesion. So similar to the one we said. This is papilloma with a bit of sclerosis or fibroepithelial lesion with cystic change. So 200, you cannot say no, because you cannot criticize. Because if 200 pathologists called it fibroadenoma, even if they are wrong, but this is their opinion. So 220 pathologists and 200, actually not 20, 231 called it fibroadenoma. At the same time, 460 called it papillary lesion. So, the second one, this is the one. So look at this, fibroadenoma, 36 pathologists. 290 called it papilloma, which is complex sclerosing papillary lesion. So when we have something like this, very, very papilloma with a lot of sclerosis and fibrosis and something, so we will have some called it sclerosing adenosis. Definitely is not sclerosing adenosis. This is not sclerosing adenosis. This is outlier. So you had 32 pathologists called it sclerosing adenosis, which is actually 34. So 34 called it sclerosing adenosis, because this cannot be sclerosing adenosis. This is either complex sclerosing lesion or complex sclerosing papillary lesion. It cannot be sclerosing adenosis. Sclerosing adenosis, you should not have this structure. It's just glands entrapped and compressed. Okay? Sclerosing adenosis benign, complex sclerosing lesion is B3 category. And the clue is these areas. It is okay? Sometimes we get, this is get something like this. I will call it fibroadenoma. Would you agree with me? But look at the stroma here. It's a bit cellular here. So if we vote, we will call it fibroadenoma. Benign phylloides, borderline between. You mean overgrowth? It's not overgrowth, but it's a bit stroma cellularity pushing the epithelium into slightly. And this is the only image I have. I'm just for demonstration. So look at the answer. So fibroadenoma 260, but you still 351 benign phylloides. Why is it called it benign? You need to understand why others are calling it. So 6 is split, 60-40. This is split. So the idea is because of prominence of intracanalular growth pattern mimicking clifting here, okay? And you have stromal cellularity as you can see in areas. But again, personally, I will go for cellular fibroepithelial lesion favoring cellular fibroadenoma. Although you have 350 called it benign phylloides, I'm not saying. You need to understand, even if you call it fibroadenoma, as I mentioned, you need to mention that it is overlapping features between this and this. I favor this. Because what happened if we call this benign phylloides, I realize that we are calling a lot of cases now coming to us with this appearance as benign phylloides. So we started to actually reduce the threshold to see that we can accept, unless if you have evidence of the stroma is pushing and it looks nasty, it looks neoplastic and progressing. Something like this is, do you call this benign phylloides tumor? Don't look at the table, look at the image. Benign or borderline? No, I mean initial diagnosis. Initial diagnosis. I'm not just saying because I know that benign. So 320 could be benign. Agree with you, but unfortunately 285 could be borderline. So can you see the split between the so this is and 350 pathologists from UK, not trainees, not resident. You know, they are, you have to respect this. So some cases these are overlapping cases in the spectrum. So you have borderline, you have benign, you have cases like this. So for these cases, we know that it is a problem is the case, not the pathologist. But look at you assess, as I mentioned. Several features should affect your classification. If you are thinking between borderline and the malignant, what about the excision? If the tumor is excised, I will relax. I will go to the side of the benign. If the tumor is not excised, and we know that borderline need excision, so you may push it slightly. So you think about the context with this. So we use our interpretation. So you assess the cellularity, you assess the mitosis, you assess the stromal expansion and the stromal overgrowth. What about the architecture, fronding and the clifting? What about the margin? Look, examine the whole margin. Go take more tissue, more blocks, because you may get actually one of them will be malignant. So we are now disputing benign, borderline, and then you take one more block and then it will be malignant. So in these cases which you are not sure, do more. And then err on the side of the patient, which can more for patient management. So the challenge is how to differentiate between cellular fibroadenoma and benign phylloides. How to differentiate between benign, borderline, between borderline and the malignant. How to differentiate between malignant phylloides and spindle cell metaplastic carcinoma, especially in core biopsy, even on excision. So because not all metaplastic breast carcinoma positive for cytokeratin, and a proportion of malignant phylloides positive for cytokeratin and the positive for B63. So you can have phylloides showing epithelioid areas and showing cytokeratin and show, but these areas when we see the definite one, DCIS in one group, so metaplastic carcinoma, clifting is phylloides. If you are lucky and CD34 is positive, malignant phylloides. Metaplastic carcinoma is not CD34 positive. So CD34 is very important. Clifting is very important. DCS, if you are lucky, you will see adenocarcinoma component, which you don't usually see it. So how to differentiate between hamartoma? Now you see cases similar to hamartoma with haphazard arrangement of lobules, but they have cellular stroma and myoid differentiation, and you are not sure is it phylloides, and if it is phylloides, it can be up to borderline or hamartoma. So I had some cases like this coming. There is no entity described in the literature called the cellular hamartoma. I tried to convince my colleague, in the UK to include it in the guidelines, they didn't see that there's no cellular hamartoma. I said, well, how can we classify these cases? So I sent some cases to my colleague outside. They came back with any opinion. Benign phylloides, something like this. But it doesn't fit into phylloides. It is cellular hamartoma. So these cases are, when you come across these cases, think about twice. For example, if it is myeloid differentiation, SMA. If it is hamartoma, usually it will be strong SMA. Phylloides will not be very strong SMA. CD34 will be strong with phylloides, will be less with hamartoma. Haphazard arrangement of lobules. If you see a lot of lobules haphazard arranged, will be hamartoma. If you see clefting and the stroma is pushing and making fronds, this is likely to be fibroepithelial lesion, so it is phylloides. So you use a lot of and if difficult cases, send for second opinion. Okay, management, fibroadenoma discharge, no management, except if it is large, the excise, or the clinical history of rapidly growing. It doesn't affect our classification. I will call it even if they see rapidly growing, if you see anything. If I see fibroadenoma, I have to say fibroadenoma. And then they go to the patient. If the patient tells that the lesion is growing rapidly, they have to excise. Why? Because if they leave it, it will continue to grow. So today it is 3 centimeters, tomorrow it will be 5, and then it will be 7, and then it will make management difficult. So they excise rapidly growing or large, more than 5 centimeters or more than 3 centimeters, based on the guideline. Hamartoma is the same. Hamartoma can recur, by the way. Hamartoma, I have seen at least 4 cases of hamartoma recurred as hamartoma. So it is the recurrence doesn't exclude hamartoma. If it is benign phylloides, now you don't re-excise. So tell your clinician, because they do. It happens with me several times. We call it benign phylloides, and then next time you get shave excision, re-excision. I say, why you have done the excision? This is because of phylloides. I said, but this is benign. Said, you know? So it is a bit of if you have benign phylloides, write in your report. Something very important, please write in your report, make your report clear for the clinician. Don't assume that the clinician will understand the report. I have seen, last week, I have seen endometrial biopsy coming. And the reason for sending the specimen previous abnormal biopsy. So I said, what is previous abnormal biopsy? Is it atypical hyperplasia or what? So I checked, I found the report says that endometrial biopsy, something inactive and fragments of endocervical tissue showing microglandular hyperplasia. So the clinician took the word hyperplasia and re-biopsied the patient. So if you wanted to write microglandular hyperplasia, say benign, hyperplastic, not uterine, make it in a different line. So don't write it in one, you know, so you don't follow. Dermoid cyst, the surgeon was complaining, the pathologist wrote dermoid cyst without specifying benign or malignant. I said dermoid cyst. So we are not educating them, we have to deal with them. So write in our job is to write in the report a report that can be understood by the clinician, that you don't have to go back and read the paper to know what's the difference between this and that. So if you have benign phylloides tumor, right, follow up is recommended. No re-excision is advised. So because phylloides, benign phylloides, no need to re-excise. All the guidelines now change it. They stopped the re-excision. They said if it comes back, you can excise. The upgrade from benign to malignant is very rare, very low. So no need. But if it is borderline or malignant, you need to have excision. There's a lot of difference now between or debate what is the best minimum margin for borderline and the malignant phylloides. And the guidelines is variable. So some said 1 centimeter, now 3 millimeter, and some said 5 millimeter. So again, you need to, when you have a case that's phylloides, try to take the margin and take the nearest margin. Don't take the one with them. So usually when they send the phylloides, you don't send it like cancer. Cancer, usually you get the specimen and intact specimen and the tumor in the center. When it is fibroepithelial lesion, usually you get fragmented specimen. And so if it is borderline or malignant, you need to have complete excision. Malignant why do you need to differentiate between borderline and the malignant? Borderline is just a complete excision, that's it. Malignant can, based on the degree of malignancy, based on the patient, based on the size of the lesion stage, and they can be radiotherapy, and sometimes if it is metastatic or recurrent, it can be chemotherapy. And when it is metastatic, it is very aggressive, much worse than carcinoma. So malignant phylloides behaving badly is a killer. It's not something you play with. So if it is aggressive malignant tumor, this you need to be considered. And this is the guidelines. If you look at the guidelines, completely different between this hospital and this hospital. See, NCCN guidelines different from UK guidelines, from Canadian guidelines, from European guidelines. They each you have, because there is no, we cannot decide which one is the best. What is the 1 centimeter is too much. We agree, but what is the minimum? Okay, when we assess, when we classify, we look at stromal cellularity, stromal cytological atypia, stromal mitotic activity, stromal expansion overgrowth. What is the difference between expansion and overgrowth? There is nothing called in the book is called expansion. But when you see expiration, like the case we have seen, when you see separation, but not enough for overgrowth, this is expansion. This is not in fibroadenoma. You see it as a feature of favoring phylloids. Expansion is overgrowth when it is more than 10 objective, when it is more than 10 objective in a core biopsy, or 4 objective in excision specimen. So if you have power 4 and you look at the slide on excision specimen and you see stroma without epithelium, this is called overgrowth. In a core biopsy, they use power 10. If you have stroma without epithelium, it's called overgrowth. Margin or border. Border, is it circumscribed or infiltrative, diffusely infiltrative or focal infiltration, heterogeneity, and the malignant heterologous element. So based on this combination, you have 8 variables. Imagine how many situations, how many scenarios. And each variable is subjective. And the cutoff is subjective. So you cannot blame ourselves. It is the tumor should be blamed. So and if it is malignant, the easiest one when it is fibroadenoma, or when it is malignant heterologous element, osteosarcoma, or but when it is in the middle, it's a bit, unless the tumor is typical features of benign phylloides or borderline phylloides, it will be difficult. But again, as I mentioned, because several features you assess together, we have to be careful. Cellularity can be no cellularity, like in fibroadenoma. Sometimes highlights the fibroadenoma. You don't have any cellularity. Sometimes mild increase, or moderate or marked. How do you assess cellularity? By overlapping of the nuclei. If the nuclei are separated from each other, this is mild. If there are a lot of nuclei, moderate. If they start to overlap a lot, this is marked cellularity. And atypia is not different. Is different from atypia of the epithelium, because this is atypia of the stromal cells. So you compare with the fibroblast. Don't compare with the normal epithelium. And we use the usual features of atypia: hyperchromasia, irregular nuclear features, prominent nuclei, the distribution of the, so use the feature size, variation in size and shape. Okay, so several features to assess atypia. So this is cellularity, no cellularity, mild cellularity, moderate, severe, easy, atypia, mild atypia, moderate atypia, severe atypia. So you can see this is because you are overlapping, dark hyperchromatic, okay, compared with this one, for example. Okay, and this is called the intracanalicular growth pattern. This is precanalicular growth pattern. You can have, this is intracanalicular. Can you see the difference between the intracanalicular in fibroadenoma and the intracanalicular in phylloides? So the stroma are pushing. This is called the frontis. Can you see this area? Stroma is pushing the epithelium. That's why you have this area. This is called the front. Can you see this is front? This is front. Can you see this bit? So the stroma is pushing the epithelium, making clefts and pushing this part is front. So this is phylloides. You can get prominent intracanalicular growth pattern in fibroadenoma. Don't call it phylloides. Look at the cellularity. The cellularity is very low. So this is not phylloid. Despite the intracanalicular growth pattern, despite the fragmentation, but this is, who will say that this is phylloids? I mean, but we have fragmentation. So not one single feature doesn't make, except if this feature is very like cellularity on its own. If it is very severe cellularity, this is, if mitosis is 20 mitosis, you have to respect. If severe atypia, but fragmentation, something like this, you have to consider the context. So the margin, even in phylloides, you can have circumscribed margin. I know time is passing, but this is margin. You can have irregular margin. You can have clusters outside. So this is infiltrative margin. Or you can have fat. Any fat infiltration is invasion. So because fat is the tumor grow like what you see in fibromatosis, in metaplastic carcinoma, in phylloides, this is fat infiltration. So look at the periphery. Entrapped fat means infiltration. Okay? Heterogeneity is one of the features of phylloides, not of fibroadenoma. So you see area hypercellular, area hypocellular, and so on. Something like this. So this is in one area, they look like fibroadenoma or benign phylloides. In this area is borderline phylloides because there is mitosis and atypia in this area. Okay, so you have intra. I think time is. Thank you very much. It was my pleasure to be with
Thank
you.
you,
today.
thank you, thank you, Dr. Ahmed. I think we need more session for the missing parts of our lecture. Thank you for all what you introduced to us. Now for the next session.
Now, let's move to the second part of the session. We will start with Dr. Yasmin Jamil. She's a radiology specialist, and Dr. Safi Hosni, a pathology consultant at Bahia Hospital. They will jointly present the radiology pathology correlation of fibromatosis.
السلام عليكم جميعا. وبجد الواحد قاعد مستمتع يعني بكل السيشنز اللي اتقالت. وشكرا جدا دكتور عماد، تعبنا حضرتك جامد. هي مش منقولة. أدوس؟ أستنى؟ نبدأ. طيب بسم الله الرحمن الرحيم. زعلت من جمال. تمام. Okay, to define fibromatosis, it's slowly growing infiltrative spindle cell neoplasm that accounts for less than 0.2% of tumors of the breast. It is considered a borderline tumor, which means that it is locally aggressive, but it do not metastasize. The median age ranges from the 3rd to 5th decade, but any age can be affected. Its origin could be primary from the breast parenchyma or the breast mesenchyme itself, or it can arise from the posteriorly pectoralis fascia of the chest wall, or anteriorly dermis and subcutis, and then extend to the breast parenchyma. It usually presents as a non-tender, poorly defined, palpable firm mass. Rare presentations include breast pain and nipple discharge. 90% of the cases are sporadic, and they may be related to prior injury, including just the direct trauma to the breast, any previous operation or intervention, and also application of implants. 10% of the cases are related to familial adenomatous polyposis. Recurrence rate is about 29%, which is lesser than fibromatosis in other sites that may reach to 50%. The classic management is surgical excision with negative margins, but there are other options, such as just watchful waiting for asymptomatic patients, adjuvant radiation for patients with multiple recurrences, or even just radiation from the start without any surgery. And these other options are due to the fact that surgery itself is considered another trauma to the breast, so it can aggravate the condition more. And unlike other breast carcinomas and unlike phyllodes tumor, here in fibromatosis, marginal status is not a reliable risk factor for recurrence.
Radiological features of breast fibromatosis include a speculated irregular non-calcified mass is considered the most common mammographic finding. On breast ultrasound, it typically appears as a solid, speculated, or microlobulated irregular hypoechoic mass, which is very difficult to differentiate from malignant lesions, therefore it's a cancer mimic. Sometimes it appears with straightening and tethering of the Cooper's ligament. Breast MRI, fibromatosis of the breast is usually seen as an irregular breast mass. In T1, it appears as an ill-defined hypo to iso-intense mass. On T2, it usually shows a heterogeneously hyper-intense signal. In T1 with contrast, it often shows a suspicious slow enhancement after contrast administration. MRI is often useful to show chest wall involvement in selected cases prior to surgical planning.
So grossly, it usually appears as a poorly circumscribed or partially circumscribed non-capsulated mass. The tumor size is much variable. The cut surface is usually rubbery to slightly firm and whitish.
Our first case here is a 25 years old female. She presented with right breast lump of 2 months duration. On mammography, no speculated mass lesions were detected, nor by additional tomosynthesis. There were no grouped microcalcification. There were no any suspicious criteria in her mammogram. However, the ultrasound was key solving in this case. It shows right breast upper inner quadrant hypoechoic irregular speculated solid mass measuring 16 and 14 millimeter. It was categorized as by RATS 4B, and histopathological assessment was recommended.
On excision, we received a fibrofatty breast tissue containing an ill-defined mass 1.5 by 1 centimeter. And this low power view, we can see clearly the aggressively infiltrative borders of the tumor. So we described such case as interlacing, sweeping fascicles of moderately cellular, uniform blend-looking spindle cells having blend-looking spindle cells with pale nuclei and pinpoint nuclei. Mitosis was almost not seen, and the stroma is densely collagenized, containing inflammatory cells. The immunos came supporting the diagnosis. Both cytokeratin and CD34 was totally negative. Ki67 showed a low proliferation index, about 2%, and beta-catenin was diffusely and strongly positive.
Our second case is a 61 years old female. She came for screening. Her only complaint was breast pain. She had history of previous right breast abscess drainage 9 months ago. On mammography, we discovered a right lower outer quadrant irregular dense mass, as well as post-operative changes and scoring. AI score gave her 84% suspicious score. On ultrasound, a subdermal heterogeneously hypoechoic irregular mass was detected. It was vertically oriented, located at 8 o'clock zone scene position, surrounded by echogenic halo. It measured about 18 and 10 millimeter in maximum diameters and showed appreciable internal vascularity on color Doppler application. All these criteria, our mammographic and ultrasound characteristics are typically a malignant mass. It was categorized as by RATS 4C, and histopathological assessment was advised.
We received this core biopsy, and it was a monophasic spindle cell neoplasm showing no ductal or epithelial component. There was apparently the gapped ectatic blood vessels characteristic of fibromatosis. On excision, we received a fibrofatty tissue containing an ill-defined mass 2 by 1 centimeter, and all the features that we described in the previous case are applicable here. Just we can see that cellularity is much higher, and the immunos came the same. Beta-catenin strongly and diffusely positive. CD34 is negative, just highlighting the blood vessels. Ki67 was low, 2%, and cytokeratin was also negative.
Our third case is a bit surprising, and we will discover why when Dr. Sophie describes her pathology results. She was a 64 years old female. She presented with right breast lump of 2 months duration. On mammography, a right upper outer quadrant partially obscured dense mass was found. It was 18 and 14 millimeter in size, and the AI score was 88% suspicious. By ultrasound, it showed an upper outer quadrant hypoechoic, ill-defined speculated solid mass surrounded by desmoplastic reaction. It was located at 11 o'clock, measuring about 19 and 25 millimeter, and it showed mild internal vascularity on color Doppler application. It was categorized as BI-RADS 4C, and histopathological confirmation was advised as well.
So this was the biopsy that we received. This photo looks low grade, but there was some epithelium there in the biopsy also, epithelial component, some ectatic vessels, very, very low grade features. And I will postpone the diagnosis till the end. This case underwent wide excision, and we received fibrofatty tissue, including an ill-defined mass, 2 by 1.8 centimeter. It was not so large. Microscopically, we can see the low-grade features, the entrapped breast ducts that we may interpret as being just entrapped ducts, ectatic ducts of the breast and just entrapped, or being a component of another tumor, a biphasic Phillude's tumor. Cellularity was alternating, zones hypocellular, zones moderately cellular, and there was very low mitotic activity, collagenized stroma, all the features that we are talking about, that it may suggest that it is a fibromatosis case. So what do you think the immuno results came? This is CD34, it was totally negative, so it's not with Phillude's tumor. This is KI67. With eyeballing to the whole slide, it was about 10%. It's not so much of help. Do you see this weak positivity in the spindle cells? What do you think? What do you think this marker is? And this is beta-catenin? No, this was cytokeratin 5/6. It was strongly and diffusely positive. And this was cytokeratin. Yes, it was not diffuse and strong all over, but it's specific positive reaction in the spindle cells. So this case is diagnosed as fibromatosis like metaplastic carcinoma. Yes, it is of good prognosis in the metaplastic group, but it's still a carcinoma that we should not interpret as being fibromatosis or any other spindle cell tumor. So this is the most important part of our presentation, the differential diagnosis of the low-grade spindle cell tumors of the breast. Always think about metaplastic carcinoma. It should pop to the top always when I see a spindle cell, although it may be low grade and benign looking. Phillude's tumor also, the benign mainly and the borderline can be mistaken. Nodular fasciitis, even the bland myofibroblastoma, the PASH, the myoid hamartoma, as Dr. Ahmed was mentioning. We should not forget about the primary neural tumors of the breast, and also the primary sarcomas, such as angiosarcoma, which will be positive for the ERG and the CD31. So we do mix and match all of these markers together to find the best diagnosis and not to interpret any tumor wrongly. And this is a wider scheme for all the spindle cell lesions that may arise in the breast, including the biphasic, the monophasic, the high grade, the low grade. And here is the fibromatosis. It is a spindle cell lesion, low grade of fascicular pattern. Interestingly, the nodular fasciitis and the spindle cell nodule, all of them are related to prior trauma.
Our take-home messages from a radiological point of view include fibromatosis of the breast is considered a rare breast tumor, yet it accounts for less than 0.2%. Ultrasound solves the mystery in young ages and adenotic breasts, where the mass may not be detected by mammography, as most of them are ACRC or D. It can mimic more sinister types of breast cancer on both imaging and clinical features. Therefore, histopathological assessment is the gold standard for diagnosis, and surgical excision is the treatment of choice.
So to sum up, fibromatosis is a pathologic diagnosis, and as Dr. Yasmin said, clinically and radiologically, it's a mimic for carcinoma. And we should do the immunohistochemistry and on the basis of the biopsy in order to, especially the cytokeratin and the epithelial markers, in order not to miss things like metaplastic carcinoma. And always the MDT sessions with personalized individual treatment for each patient remain the best. Thank you.
Thank you, Dr. Yasmin and Dr. Safi, for your nice presentation. Now we'll move to the second presentation, named Radiology Pathology Correlation in Complex Fibroadenoma, well presented jointly by Dr. Mahmoud Bekhimer and consultant radiologist at Bahia Hospital, as well as was the Dr. Mona El-Barak, consultant pathologist at Bahia. Abrak. Oh, sorry. Abrak, consultant pathologist at Bahia Hospital.
بسم الله الرحمن الرحيم. السلام عليكم. ان شاء الله النهارده هنقدم complex fibroadenoma radiology pathology correlation. Presented by Mahmoud Ibrahim Khimar and Dr. Mona Al-Abrak. Fibroadenoma are common benign breast tumors, are most common in women in their 20s and 30s, but they can be seen at any age. From radiological point of view, fibroadenoma comprise epithelial and stromal component and can be classified into the simple type. This is the most commonly seen adenoma. They are oval or rounded with circumscribed margins, appear hypoechoic on ultrasound, and in MRI they contain dark internal septations. The second type is the juvenile fibroadenoma. They occur in young patients. They are rapidly growing but eventually shrink. The third one is the giant fibroadenoma. They are larger than 5 centimeters, should be differentiated from phylloid tumor. The last one is the complex fibroadenoma. They are rapidly growing. They contain internal calcification and cystic spaces. By mammography, fibroadenoma appear as single or multiple circumscribed lesions with oval or rounded or macrolobulated outline. They appear as hypodense, hypo, or hyperdense to glandular parenchyma with obscured margins. In older age, they undergo calcification, producing the classic popcorn calcification, but in some cases, calcification may present as sand-like crushed microcalcification, which makes the differentiation from malignant lesions different, and in these cases, they need further steps. By ultrasound, they are rounded or oval with circumscribed margins or lobulated margins. They appear hypoechoic or hyperechoic, and the popcorn calcification produce dense posterior acoustic shadowing. If fibroadenoma appear irregular in shape with obscured margin or cystic spaces or internal microcalcification, further steps should be done to reach the final diagnosis. When to suspect complex fibroadenoma? When there are cystic spaces, they are irregular outline, hypervascular, and increase in size, or internal microcalcification. In these cases, they should be surgically removed.
In pathology point of view, the fibroadenoma is a biphasic tumor showing proliferation of both the glandular and the stromal elements. It can be usually associated with usual ductal hyperplasia, epicrine metaplasia, cyst formation, squamous cell metaplasia, but those association does not say anything. It's just an association. Two types of growth patterns are there. It's the intracanalicular and the pericanalicular. Glands for intracanalicular are compressed into linear branching structures by proliferating stroma, while the pericanalicular, the glands retain an open lumina, بس فيها expanded stroma. The variants of the fibroadenoma are either mucinous with prominent myxoid stromal changes, or cellular with diffuse stromal hypercellularity, or juvenile with both increased stromal cellularity and increased epithelial hyperplasia in a gynecomastoid like micropapillary projections and the complex fibroadenoma, which is our topic today. What do I say? How can I say fibroadenoma? It is complex when one or more of those features are present. A cyst larger than 3 milli, not less, sclerosing adenosis, microcalcification, and papillary apocrine metaplasia, not just apocrine metaplasia. Case 1.
A 31-year-old female patient complaining of left breast lump. Ultrasound showed oval circumscribed hypoechoic lesion with internal cystic spaces and increased vascularity. Tissue biopsy was ordered.
The core showed fibroadenoma وفيها cellular stroma. On a closer look, we have here a papillary apocrine metaplasia. This focus. In the other focus, there was a cyst larger than 3 milli. And the diagnosis was cellular fibroadenoma with complex features. On surgical excision, fibroadenoma with cellular stroma, and there's another focus of papillary apocrine metaplasia, and cysts multiple cysts larger than 3 milli. And there was an associated usual ductal hyperplasia. So the diagnosis was the same, cellular fibroadenoma with complex feature and associated usual ductal hyperplasia. Case 2.
A 42-year-old female patient complaining of bilateral breast lump. Mammography was done and revealed bilateral few scattered isodense lesions with the left breast upper inner quadrant lesion containing heterogeneous calcification. On ultrasound, this lesion on the left breast appeared as oval hypoechoic lesion with microlobulated outline and internal calcific foci. Tissue biopsy was ordered.
The core showed fibroadenoma, and على low power واضح ان في sclerosing adenosis. This is with a higher power, and another focus of sclerosing adenosis. This is what it looks like, and the diagnosis was upfront complex fibroadenoma. On surgical excision, we found fibroadenoma, sclerosing adenosis. It seems like that, with associated microcalcification, as we see here and here and here. Another areas of microcalcification and sclerosing adenosis. So it was granted the complex fibroadenoma. Case 3.
45-year-old female patient complaining or just coming for screening. The initial mammography was done and revealed left breast deeply seated isodense lesion and was classified as BIRAT 3 for follow-up. On subsequent mammography, there was subtle increase in size of the left breast deeply seated lesion, and also by ultrasound, there was subtle increase in size and the change of the shape of the left breast lesion, so tissue biopsy was ordered.
The tissue biopsy showed, as we see, fibroadenoma. Okay, أكيد complex papillary أكيد complex. هنا كنا شايفين papillary apocrine metaplasia, بس كان في focus associated suspicious. But we did some marker CK56. This was the suspicious focus on high power, and the CK56 was negative, while the CK was highly positive, very strong positive. ER was positive. PR was positive at the same area in the HER2/neu. يعني كان في التissue كان exhausted, but it was negative. And this case was granted complex fibroadenoma with focal involved by invasive lobular element and was recommended for complete excision. Upon excision, actually, she received post-neoadjuvant chemotherapy because she has on the other side there was invasive duct carcinoma, and that's why she received neoadjuvant chemotherapy. And she was on this complex adenoma and invasive lobular. She was granted right breast simple mastectomy and sentinel lymph node biopsy. The invasive lobular carcinoma was grade 2. There was a complete therapy effect within the breast, but there was macro metastasis in the lymph node, and this was the area with therapy effect in the breast, and this is the residuals of the cysts, which is larger than 3 milli. So surprise can happen. So to sum up, the complex fibroadenoma in the radiology point of view is
We suspect complex fibroadenoma when there are cystic spaces, they are irregular outline, they are hypervascular and increase in size, they contain internal microcalcification.
And as we saw, there should be cysts larger than 3 milli, or sclerosing adenosis, or microcalcification, or papillary apocrine metaplasia. So it's complex, but it's not complicated. Thank you.
Thank you for the good presentation. Last speaker in the session is dear Professor Sahar Mansour. She will discuss the screening workshop cases. Professor Sahar Mansour is a professor of radiology and managing director of the presidential campaign for screening of breast cancer in Egyptian women, Asr Al Aini Hospital, Cairo University.
Good afternoon. دي آخر بقى حاجة في السيشن. I'll start with breast cancer screening cases, and although AI had the potential in the field of screening breast cancer, there are still issues. It is vital to make sure that the AI doesn't overlook the cancer or cause needless recalls. The AI algorithm that we use at Bahia, it's a commercial setting product that show the cases in form of a pixel level abnormality scores as a heat map, where the intensity of the color hue increases from cold colors to intense colors according to the probability of breast cancer. And there is a representative of pixel level abnormality scores in a numerical estimate according to the degree of suspicion of malignancy in the abnormality seen, which is from less than 2% to 100% scoring. Then we get multiple estimates from probably non-cancer, possibly non-cancer, possibly cancer, probably cancer, according to the enhancement of the percentage. And I start with case 1. This case, I'll go first as a human reader, and I say it is negative or for recall. I may say for recall, benign or recall malignant. Well, I may go for the left breast. It's a benign recall, but yet the AI gives me that the left breast having, the right breast having an upper outer quadrant 77% scoring of malignancy. So I go with the AI for the complementary imaging and biopsy, or stay with my probability that I'm having the left breast with the symmetry in the upper outer quadrant. I did the magnification view. There is calcification tracing the glandular tissue and subtle distortion. I assume it is adenosis or glandular changes. And when at the stage of the ultrasound, it was Dutch cystic changes, and the lymph nodes is the non-specific benign looking lymph nodes. So actually the case for me, it's benign, and schedule the patient for an annual follow-up. After 1 year, the left breast asymmetry is the same with the fat lucences with them, and I confirmed it from the last year that it was cystic changes, but about the right breast upper outer quadrant, it was 77%, is now 99% by the AI scoring, is definitely cancer. I get the patient for the magnification view. Definitely it changes from the subtle distortion and the calcification tracing the glandular tissue with the intervening fat and normal glandular tissue within to increase density and distortion and cluster calcification. And the ultrasound established mass with the malignant looking lymph nodes. More confirmation with the contrast enhanced mammogram, skin dimpling and distortion. It was invasive ductal carcinoma. In the barrier mammogram, the one that was in the workshop, actually I had some clues that I'm dealing with suspicious lesion, which is the grouped calcification, the subtle distortion, and the AI marking, which was 77%. So please, when you have subtle changes in postmenopausal women with AI marking and you found no ultrasound correlate, kindly give the patient the chance for close follow-up with another AI marking, because increase in the marking of the AI is suspicion of the items that I'm dealing most likely with a suspicion item. Case 2. The patient is 30 years old and have this area which is so much evident in this dense breast in the upper outer quadrant of the right breast. When I go with the asymmetry for the first site, I find it suspicious. Is negative or recall? Yes, it's recall. Recall benign or recall malignant? I say it's recall malignant. I get the patient for the ultrasound. The AI gives me the score of 96%. It's highly probable that it's being a cancer. And so I'm now so much confident that the patient had to be recalled for ultrasound and biopsy. And at the level of the ultrasound, it was just a cluster of microcysts. So it was on the biopsy, proliferative fibrocystic mastopathy with duct papilloma. And sometimes the condensed cysts give a false impression to the eye that I'm dealing with malignancy due to increased density and the clumping of the tissues with condensation. So if you see a change of the patch or the asymmetry from the CC and MLO, you could find the loosened fat signal within the density. And if there is the maintained Cooper's ligament stretching along the lesions, like this here. This is the Cooper's ligament, the normal Cooper's ligament here. It's preserved, there is no infiltration or distortion, and the symmetry changes from the CC to the MLO with the fat lucences is still preserved because it's not a malignancy or soft tissue infiltration. It just condensed glandular tissue. So even the AI gives a 96% and enhanced color hue, the biopsy will only for exclusion of the malignancy and not because there is actually a malignant process, and it's more favorable to be through a vacuum assessed. Case 3, I guess it's obvious that I'm dealing of a lesion in the left breast. If I get more spot to the left breast upper outer quadrant, I could spot this lesion is very tiny, it's speculated. This time, even if the eye have no scoring, I'm confident about it, but yet it gives me 91%, so both of us going the same way, it's confirming of the malignancy. I'll schedule the patient for ultrasound and biopsy in the same session. No need to at the time of the patient for just the ultrasound and recall for the ultrasound. No, please take the 2 sessions at the same time. It's a very tiny tumor. It's about 4 millimeter, and the lymph nodes look suspicious itself. More confirmation with the contrast enhanced mammogram. It's a unifocal carcinoma. Case 4, it's 42 years old female, came for a screening mammogram. At the first sight, I think it's normal. I go to both sides, there is nothing wrong with the breasts. AI also gives me no marking, so I guess this time we both, the AI and the reader radiologist going both ways. That is negative mammogram. I schedule the patient for annual follow-up with so much confidence and no need for ultrasound. Well, actually, no, because I'm having indirect signs of I'm dealing with the malignancy, which is the symmetrical increase in density, the tissue peaking, and obliteration of the subdermal fat. So I recall the patient for ultrasound. There is the mass with the distortion and the malignant-looking lymph nodes. Contrast-enhanced mammogram, there is more extension of the lesion with the contrast uptake. It was invasive lobar carcinoma, so please not go for the frank malignant features of the mass, asymmetry, calcification, and distortion. No, go for another indirect signs of malignancy, which in this case, the asymmetry in the breast density, the distortion, and tissue peaking, with other signs could be also present, like the cluster calcification, skin thickening, dimpling, unexplained change in the breast size or shape, and the increased breast density. This case also, I go in the first site, it's obvious that I'm dealing with the symmetry and the right lower inner quadrant of the right breast. So it's recall benign or recall malignant. For the first site, I found there is a change in the density shape somewhere, and the AI definitely no cancer. So I'll do the ultrasound, and there is indistinct mass lesion. At the contrast level, I'm having these multifocal masses showing contrast uptake. It was mucinous carcinoma grade 2. So if there is a discrepancy between the size of the tumor on the digital mammogram from the ultrasound, kindly ask for contrast-enhanced mammogram. This time, the information is not about the eye, it's about if I'm going to ask for contrast as my way for screening or not. If there is a density or a mass in the mammogram and it's not correlating with the size in ultrasound, go for the contrast-enhanced mammogram if I'm dealing with dense breast. This case, 53 years old, so I'm dealing with postmenopausal woman. When I go scanning for the breast with the human eye, I found there is lesion deeply seated in the right side, and what about the other side? The eye skipped the one on the right and goes for the left with 25%, is still probably non-cancer. So I go the way with the left side because I think the one on the right side looks probably benign. It's partially circumscribed and partially overlapped with glandular tissue, and I'll go for the ultrasound. I know there is a lesion in the right breast. But what about the left side? I did the magnification view. There is asymmetry, increased density, and calcification, tracing this glandular tissue. Then the next step is the ultrasound for the right side. Actually, it's not Brira 3. It's irregular, and more or less the extension is vertical rather than going in plane with the breast tissue. The left side, there was no correlate. On the tomosensor, there is a distortion. And with the contrast-enhanced mammogram, I get the brim enhancement, the center of the mass showing no contrast uptake or minimal contrast uptake, while the margin is the one showing the avid contrast. And for the calcification with no contrast uptake, I did the stereotactic biopsy. It was mucinous carcinoma grade 1 on the right side and ductal papilloma for the left side. So what is the tip for this case? Actually, if there is low marking by the AI, this doesn't mean that I'm not dealing with the cancer and to stop the investigation at that point and get confident with the AI. No. If I'm finding the features of malignancy or suspicion, I'll proceed furthermore to get other confirmation that the breast is definitely clear, because low in the AI means low risk of malignancy. It doesn't mean negative mammogram. This case is 61 years old, is postmenopausal female. I'll go for the screening, is negative or recall. I may say recall, and for the left breast, because I'm having asymmetry. But again, the asymmetry showing fat within, it changes the shape between the CC and MLO. So I'll go for its asymmetry, but it's a benign asymmetry. What about the eye? It marked the other side, the right side. So for both sides, I'll get the ultrasound, but still not at the level of the biopsy. When I get first the magnification view, in order to see what is the eye have marked, I get this cluster microcalcification with subtle distortion. The ultrasound, there was no correlate because the lesion of concern was distortion. So kindly go to the tomo, and at the tomo level, we can see this distortion is evident. It was invasive lobular carcinoma grade 1. And if there is subtle distortion, changes in the postmenopausal women, not correlating with the ultrasound, irrespective of the scoring of the AI, I have to suspect malignancy, and the modality I was going to use at the time, it's better to be the tomo and not the contrast-enhanced mammogram. This case, it's 40 years old patient. At first look, recall or negative? I'll say negative. But what about the AI? There is a 35% lesion in the central portion of the left breast. It's possibly non-cancer, so I'll get the patient for more confirmation by the ultrasound. It's a microlobulated lesion, yet it's in a plane with the breast, but needs biopsy because the microlobulation and the heterogeneity. I'll get the biopsy. It was a typical ductal hyperplasia. So the percentage of the AI more merges with the pathology that resulted. This case, negative or recall. I say recall. For the right breast, I can see the symmetry. It's so much evident. It's extending till the muscle on the right side. The eye, definitely no cancer. And actually, more or less, I can see that it changed the shape. but there is distortion, and the fat is not that evident, especially in the MLO. At the ultrasound, the mass was there. It's tiny lesion with indistinct margin. This is a carcinoma, although it's not coinciding with the side that's seen on the mammogram, but I'm dealing with the carcinoma. And then it was invasive lobular carcinoma grade 2. So please, if you find any lesion, even it looks benign, if the asymmetry changes in size, if there is cluster of microcalcification, if it was adenoma, it resumed adenoma. In the retroglandular area, this is termed as no man's land. No man's land means there is no glandular tissue in such region. So if you find any pathology, this is abnormal. This is suspicious. I can accept that there is cystic changes, adenomas, or benign lesions, asymmetries within the glandular tissue. But if you go for the retroglandular fillet, this is not accepted at all. So please, any lesion present in no man's land, kindly have a close look on it or even proceed to biopsy. This breast is busy, full of glandular tissue, no place for the fat. It's very tiring, especially if it comes at the end of the workflow. A subtle distortion I could appreciate in the upper outer quadrant of the right breast, and the patient's postmenopausal. I get it for the AI. It's spotted in a few seconds that I'm dealing with the lesion that I have found it myself. And so we are going for the same way. On the ultrasound, yes, there was this lesion and another one spotted by the ultrasound is not unifocal. And since the breast is busy, I need to go for the contrast-enhanced mammogram, especially in postmenopausal women. I'll find another one on the left breast. It's a form of a linear enhancement. So it's bilateral breast carcinoma? No. The one on the right, it was invasive ductal carcinoma, and one on the left was atypical epithelial cells on calcification. It is accepted, and so I'll go for benign pathology? No. Since the patient is postmenopausal, it's not accepted that to leave hyperplasia, typical ductal changes, epitheliosis in a postmenopausal woman. I can do that interval follow-up for a young patient with hormonal changes every now and then, so expect it to have a hyperplasia and stay as it is. Cystic changes and stay as it is. But if I have biopsy for a postmenopausal patient for contrast uptake, non-mass enhancement that incidentally found in the contrast-enhanced mammogram, it will turn eventually to cancer. Please don't leave it. It has to be excised surgically. So contrast-enhanced mammogram can detect the precancerous lesion, and in postmenopausal patient with atypical sense and hyperplasia, is a precursor for cancer and necessitates surgical removal. What about this case? It's negative or recall? I said recall. Recall for which side? It was for the right side. Yes, it's subtle, but I can see it because for the magnification, and the eye also confirmed it with the 99%. So then I scheduled the patient for ultrasound and biopsy in the same session. No need to get the ultrasound, then ask for biopsy in another session. The mass is there by the ultrasound, and it was invasive tubular and cribriform carcinoma. What about this case? It's the fatty breast. It's the breast of a choice for any radiologist. When I find this breast, it's hallelujah, I got my gift. But there is a nodule in the upper outer quadrant. It looks very benign at the first presentation of the patient. So I may give it the chance for follow-up, and the nodule looks no suspicion about it. The eye marked the nodule. It took 19% suspicion of malignancy. And for me, it's nothing. It's just a nodule. Why the eye have marked with 19%? It's probably non-cancer, yes, but it marked it. So I'll compare with previous mammograms that I'm having it. And by comparing the previous mammogram, I can find the nodule. It's there. So why not to worry? It's actually was there in the previous mammogram, and in this mammogram, it's having the same size and the same shape, so I shouldn't worry. That when I compare with the AI in the first mammogram, 2022, it showed no marking. But in 2023, it showed marking. So I should worry. Because actually, it was speculated on the ultrasound and invasive maculopapular grade 2 carcinoma. So the tip this time is the increase in the AI scoring, even if it was a subtle percentage in the follow-up screening mammogram, is a point of suspicion itself rather than the low scoring. This case is 53 years old, is postmenopausal. At the first site is negative or recall. I say recall. Recall for the right breast, lower inner quadrant, yes. It's a tiny lesion, but the AI marked a large area in the lower inner quadrant. It's probably cancer because the percentage is 80%. And then I find these multinidus of calcification is clustered. Maybe it's overlooked, but the eye marking the area let me go for the magnification and not be only having the happy eye for only the tiny, small speculated lesions with the calcification. So extension based on the AI demarcation have extended and will, of course, guide the operation to another destination. But the contrast enhanced mammography, only the lesion, the tiny lesion, is the one have got the contrast uptake. Yet the extension was different by the AI. It was invasive ductal carcinoma with desmoplastic reaction, and the tip is suspicious calcification not lighting up on the contrast mammogram. Please, this doesn't mean that I don't have a cancer. There may be lurking beneath the surface. And so calcification has to be considered even if there was no contrast uptake. Negative or recall? Recall for the right breast, and it was marked by the AI 91% for the right breast and 50% for the left breast. The right breast, the mass on the right side was evident on the ultrasound, and there is no abnormality detected on the left side. So I'll go for the magnification, and it was the clustered microcalcification. For the right side, it's invasive ductal carcinoma, and the left side is atypical ductal hyperplasia. When I compare the eye scoring with regard to the calcification on the left side, I found it was 58%, then 50%, then 42%. So I may use the eye not just for the detection and diagnosis of the lesions, could be used also for follow-up, especially if I have taken a biopsy and the lesion was confirmed to be benign. Benign or recall for malignancy. Actually, I can see no abnormality in that breast at the first sight. But the eye marked an area in the upper outer quadrant. It's 46% possible in cancer, but it was marked and flagged. So I'll go for the ultrasound. It's only a cyst and the glandular tissue, nothing to worry about. So I get the patient an animal follow-up. At the time, there is something in the left breast. Yes, I can see subtle distortion, and the percentage increase to 78%. So this time, what shall I do? I'll go for the ultrasound. I can see nothing, there is no correlate. And the patient taking another animal follow-up. This time the scoring is 95%. Please be confident with the eye scoring. And I take it a look, and there is the lesion with the speculation and infiltration of the glandular tissue and the feeding vessel, with more confirmation with the MRI imaging. Is ductal carcinoma in situ with intermediate grade cribriform and solid type. So again, subtle changes in perimenopausal women marked by eye with no ultrasound correlate. Kindly do the close follow-up with the AI marking, because increase in the signal with the percentage could be your guide that you are dealing with a suspicious lesion that is overlooked by you, even if there is the ultrasound confirmation of you having a cancer. This case, it's postmenopausal again. Negative or recall? Recall. Recall benign or recall suspicious. For the first site, it's recall benign. For the left breast, the nodule is obvious. And I get an 11% for that nodule. It's probably non-cancer. I need an ultrasound. I went to the contrast-enhanced mammogram, and the uptake was so much subtle. I suspicious these areas, but I'm not evident about if I'm dealing with a certain abnormality in that place in the upper outer quadrant and also in relation to the nodule. By the ultrasound, I get a focal distortion, but the extension is not that evident, and the lymph nodes are indeterminate. doesn't go with us with any white benign or malignant. It's still indeterminate in the midway. So since I'm dealing with a distortion in the ultrasound, I get to the another modality to be the tomo. There's multiple slices, the distortion is there. I can get, it's multi-centric, the breast is full of the distortions. I need to go through all these slices, and MLO also. But with the AI TomoSense 3D, the marcation of all the distortion is only in few seconds. I get all the areas, the extension of the disease, the multicentricity, and even a score average for all the lesions, 82% that I'm dealing with a multicentric malignancy. And it was invasive ductal carcinoma, invasive lobar carcinoma grade 2, with DCIS 5%. So now, with the 2D AI, we have an AI-powered digital tomosynthesis. If the distortion is detected in heterogeneous dense breast, it is recommended to do DBT to identify the multiple masses. This method provides a more detailed and layered view of the breast, helping to distinguish true abnormality from the overlapping tissues, and AI algorithm applied on the 3D mammogram can swiftly analyze these detailed images, highlighting areas of concern for radiologist review. This is the fatty breast again, and the patient is postmenopausal. So I have learned my lesson not to overlook the fatty breast in postmenopausal women. Please go through it with more magnification and more concern, like the dense breast. The AI shows this area here in the lower inner quadrant is 67%. I'll go for the magnification view. We have this clustered linear-oriented microcalcification. And it was ductal carcinoma in situ undetermined papillary type. So don't be fooled by the fatty parenchyma of the breast, because subtle changes might be lurking underneath, easily missed to be overconfidence that there is no glandular tissue to obscure the carcinoma. Remember, virulence is key in detecting those hidden signs. Bond, James Bond. This is the way we have to go with the mammogram on the screening basis. Be confident, precise, because if you are not, the mammogram tricks you with multiple overlaps of the tissues and the tricky features that could get you to the what I'm dealing with, the normal, suspicious, or malignancy, benign. So you have to be crucial in your work and do it like the Bond mission. I'm a spy that I'm going to get the carcinoma even if there is overlapping of glandular tissue. The classic methods of breast cancer screening primarily include the mammography. It is the most common, widely recommended screening tool. But we have also the clinical breast examination, which is the physical examination of the breast by healthcare professional to check for lumps or other changes. And actually, the clinical breast examination is recommended by WHO to be the cost-effective screening tool in the low resources limited setting found in the low and low middle economic countries like our country, Egypt. For the digital breast tomosynthesis, some guidelines suggested that it to be used for routine screening, especially in population which is more accessible and affordable. So the key scenarios is for the dense breast tissues, for the high-risk patients with BRCA mutations, and for the abnormal mammograms to detect more precisely if I'm needing recall or not. So what about the contrast-enhanced mammography? Well, it provides comprehensive imaging features, especially in the dense breast, in the high-risk patients, and this time for the previous breast cancer, in order to monitor and detect any recurrence. For the MRI imaging, it is more or less the same key scenarios with about dense breast, high-risk patients, previous cancer, and also for the high-risk lesions, that like atypical hyperplasia, lobar carcinoma in situ, it might consider MRI screening. And it could be used as supplementary screening method in inconclusive mammogram results because it gives additional details. This is the final case. Negative or recall. I'll go for the AI because I'm having that method and it could help me and could replace me and I can use it. I don't need any radiologist or go through the images. I'll find the AI giving me the 10%, so it is negative, and okay, I'll go for its assumption. How confident are we in letting AI take the lead in routine cancer breast screening? Can it outshine the human radiologist? Well, a comprehensive library of radiology diagnostic contains almost 20,000 terms for diseases and imaging findings, as well as over 50,000 causative relations. And human radiologists identify breast cancer mimics, not just breast cancer, in a long tail of distribution There is fat necrosis, granulomatosis mastitis, nodular sclerosing, postoperative scarring, and else. AI doesn't know all these informations. So AI is impressive in identifying horses, but is a long way from recognizing zebras. Without continuously learning from new data and annotated imaging update to feed the AI, it will become a static brainless machine. So however, with data upgrading, AI can assist in detecting abnormalities, writing cases, and even suggesting possible diagnosis, ultimately improving patient care. But it's not comparable to the human reader. So when I found this mammogram and the AI gave me low scoring, no, don't go with the AI and go to the easy way. No, do what the human reader do. The mirror reading, take both breasts, put them opposite each other as if in a mirror, and then start the brain mental illusions of the division into thirds. It's the method that ensures that no part of the breast is overlooked during the evaluation. So easily could find that there is an upper outer lesion in the right side with a distortion. Go for the tomo because it's a distortion. It's more confirmed, and then targeting the ultrasound, I could find the lesion. It's by REDS 5. It's malignant looking. So even if the AI tells me it's 10% scoring, not to worry about it. It's probably non-cancer. I'll go for the mirror reading and go for my usual way of reading the mammogram. And the pathology was invasive ductal carcinoma grade 2 with ductal carcinoma in situ. So are we in need to incorporate the AI in a screen to detect early signs of breast cancer? Because if he tells me negative, I will not go with him. But actually I need him in breast cancer screening? Well, we did a research in Bahia Foundation. It was a prospective research about how to get AI triage in the niche reader for double reading breast cancer, about 32,822 mammograms. It was between the 2 radiologists and 1 radiologist paired with AI. The malignant looking lesion, suspicious lesion, was confirmed by the biopsy or surgical removal. And for the negative mammograms and benign looking lesion, it were not biopsied. The confirmation was by 2 years follow-up. It included about 86% negative mammograms, 7% malignant, and interval cancers comprises about 11% of the lesions. The AI plus radiologist showed an increased rate of detected cancer by about 2.4%, and the increased recall and biopsy also by this AI plus reader. We found a cutoff AI scoring value of more than 13% for recall, not for cancer diagnosis. It's only for recall and getting back the patient. And the mean AI score for the malignant lesion was 68%. The key strengths of that groundbreaking research that the AI was used as independent reader with the radiologist hand in hand. It's an innovative approach to ensure that AI support the radiologist by identifying potential issues early on, streamlining the screening process. The second issue was the expertise of the radiologist. We included ones from the 15 years to up to 30 years experience in breast imaging. It's a comprehensive prospective study because it is the first prospective study to include biopsy results and 2-year follow-up for the normal benign cases. Also, it was performed in Bahia, which is a center of excellence. We have the ultrasound machine, the contrast, the tomo, the PEM, all the modalities in the same place. So actually, we are pretty sure that we have enabled the patient to seamless breast cancer screening experience, enabling interpretation, recall, and biopsy to be completed only in 1 session. As we continue to explore the integration of the AI in the medical imaging, we are optimistic about the future of breast cancer screening and the lives it can save. Thank you.
Thank you, Professor Sahar, for the very good presentation. Any questions? Okay, let's end our session. Thank you.
Okay.